We'll have to unmute.
Okay.
I'll mute everybody now, and then during the interaction, we can all unmute and speak.
Unmute.
Good evening, everyone. My name is Sindu Pillai, and a warm welcome to AKMG California Chapter Spring Meeting. Being the Vice President of AKMG, it's my great pleasure and pride to welcome you all to this evening. And thank you so much for joining on a Saturday evening. Let us start the meeting with a beautiful prayer by Neha Gregory. Neha?
Please unmute.
Thank you so much, Neha. That was beautiful. Welcome back, everyone, once again. I'm Sindu Pillai. I'm a graduate of Alleppey Medical College. And I finished my residency at Cook County Hospital, Chicago, and moved over to California after working there in the Chicago suburbs. Some of the Chicago physicians, I personally know them. I'm in Marietta, California. It's like an hour south of San Diego, if you don't know Marietta. and I'm in private practice, and since 1999, early 99, I'm in Marietta practicing pediatrics. I'm staff at Loma Linda Marietta Hospital and also Southwest Healthcare System, which includes Rancho Springs Medical Center and Inland Valley Medical Center. I have been part of actively participating in AKMG activities under leadership of Dr. Radha Menon since early 2000. Actually, I have attended one of the earlier conventions in Hawaii, that was 2003. And since then, I have been participating in AKMG, several conventions from the east to the west and Canada and all. In 2019, I was fortunate to enter the Board of Governors. And last year I was secretary and treasurer. And this year I'm very proud to say I am the vice president of AKMG. And thanks to everyone, thank you to all the leaders, all my mentors, past presidents, for all your guidance and support. I'm really, really thankful to all of you. Those who are new to AKMG, I just would like to say a few words about AKMG. What is it AKMG all about? AKMG has been, Association of Kerala Medical Graduates, has been the premier and pioneer alumni organization in North America, USA and Canada for medical and dental specialists of Kerala origin. It was originally formed by a group of physician friends in the end of 1970s. And the first general body meeting was held in Bombay Palace, New York. And since then we had annual conventions, and the organization has grown remarkably in the last 4 decades. We are getting ready to celebrate our 43rd convention this August 4 to 6 under the guidance of Dr. Nijal Haroon coming up in Toronto, and we are all looking forward to that. Now, what is AKMG is all about? Like we said before, Dr. Usha Iyer was saying, it is all about friendship. It is about getting to know each other. AKMG is like a large extended family. Every convention that we go to, we feel like we are celebrating a big family get together, get to know each other, share experiences away from home, or physician colleagues and friends and so forth. I was talking to one of the younger physicians, but I was talking to all the physicians in California, and I happened to talk to one of the young physicians of California, and I was very happy to hear that. She was telling me, oh, I know all about AKMG, Auntie. I have been attending every convention when I was a child, since early childhood with her parents, and I'm very happy to be part of AKMG. So when I called these young physicians, they all picked up, they all talked to me, and I was very happy to hear that. And we have a lot of young physicians in AKMG California chapter, and we will be introducing them shortly. So it is stay united. It is the history of AKMG. It's the tradition of AKMG to be together, to be united in a family, under a family umbrella of a family. What are some of the other things AKMG does? It is actively involved in educational and humanitarian services. It's an AKMG CME committee where we can attend CME, a lot of presentations by AKMG well-known physicians. We do have 2 excellent talks today planned, and one of the talks has CME credits, as you all know. We have AKMG mentorship committee, where we have a team of physicians who's helping young physicians, medical students and residents to develop their career, to be leaders and develop their career in the professional field. We have AKMG humanitarian services. We have done so many charity projects, and a few of them are AKMG Helping Hands project, which was inaugurated by around Kerala Piravi, where we help talented artists who need help, especially during the pandemic times. We have the largest philanthropic undertaking that we took as AKMG COVID support project, where almost 70 community organizations have joined hands with AKMG and also with the Global Medic, a reputable international disaster relief agency. And they were of immense help to us in supporting us to do this project. And we are very happy to say that, very proud to say that we were able to deliver almost 20 million masks. Dr. Haroon will talk more about that, I'm sure. And almost 2,000 pulse oximeters to Kerala, to our motherland, with the help of...
We're providing billions of dollars for affordable home lending programs.
Another major humanitarian services that we have done, two of them are Kerala Flood Relief Fund and also the Jeeva Jalam project, where we were able to distribute freshwater water filters to Kerala during that flood relief time. Now, let's say a few words about AKMG California chapter. Our last convention, the two conventions that I attended, I remember one was 2003, that was in Hawaii. We have a lot of beautiful memories of that event. And then we had, under guidance of Dr. Radha Menon, in 2008, in Newport Beach is our last California convention. And just last week, February 25th, we lost a very, very important part, integral part of our AKMG, especially California chapter, and that is Dr. Joseph I. We all know that. He was an integral part of our organization. He was a big leader. He was guidance for all of us. And his vision was to bring AKMG to California. And he was the president of the convention held in San Diego and also Hawaii. And he was in the advisory panel for our convention 2008, Newport Beach. He was a great leader, and it will be a big loss for AKMG, especially AKMG Western chapter. Let's all keep a moment of silence in Dr. Joseph Ives' memories. Thank you so much. So AKMG California chapter, we restarted. We restarted the chapter again in 2019, and we had a physical convention. We did in Anaheim, one of the restaurants, Tamba restaurant in Anaheim. We did have almost 35 to 40 physicians attended that convention. Then we were all hit with the pandemic. So the last convention was again, just like today, it was March 6th of 2021. We have a virtual convention. It was very successful. And then now we are here on exactly a year from the last one. Again, it's a virtual meeting. So I would like to right now, Gregory, please show we have a slide. I would like to introduce every member of California chapter, but because of the time constraints, we are not able to do that. So we do have a list of physicians, and we almost have 80 physicians in our California chapter right now. And here is the list. The picture is a little bit blurry, but here was Dr. Ives' vision to bring AKMG back to California. And now I already mentioned that we are already past 4 decades, and we are getting ready to do our 43rd convention. Very proudly, we are saying, we can say that we are looking forward to that convention from August 4 to 6 at Toronto, Canada. So I'm very happy to introduce and welcome our president, Dr. Nijal Haroon. And if I start talking about Nijal, I would not be finishing today. There's so much to talk about him, but I'm trying to make it brief. He's a world-renowned rheumatologist, a clinician scientist at the University Health Network, and he's the associate professor of medicine and rheumatology at the University of Toronto. He has been recently selected as the new head of the Division of Rheumatology for Sinai Health System and University Health Network as of April 2022 for a 5-year term. He has received multiple awards involving the prestigious Vanier Scholarship, He was the Young Investigator Award of Canadian Rheumatology Association and Distinguished Alumnus Award of his Alumni Medical College, Trivandrum. He has published numerous publications, numerous journals, and he's authored chapters in several textbooks, including the 21st edition of Harrison. Super smart young physician with a very incredible knowledge, successful, so many achievements at this young age, a scholar, a speaker, a singer, whatnot. Here we have Dr. Nigel Haroon, our current president of AKMG. Warm welcome to AKMG California chapter meeting, Nigel.
Thank you very much, Chandra. A very, very generous introduction. And if it's any clue to my abilities of singing, she said you don't have to sing today. So take everything with a pinch of salt. We've got great people presenting today. Again, a pleasure to be here. Thanks to all these programs, we're able to connect repeatedly on digitally, virtually. Before we all come together in Toronto in August. So hopefully we'll see you all here. We have a fantastic program ready for you. We have a video later just as an intro and a welcome for you later. But today I will just, because we've had programs almost every month, I'm just giving the latest update here. I wanted to just share 2 programs that are coming up and an update on the programs that we have done so far. So one is, this is very new for AKMG. We are launching a leadership course, and this will be coming online very soon. Marina George, who is the VP of Inpatient Medical Practice at MD Anderson, she's kindly agreed to be a course director with me for this program. And the whole idea is to introduce the concept of healthcare leadership to our members. Some of our members who were fortunate to be practicing and working in large academic centers may have smaller programs like this, but a lot of our members don't have access easily to healthcare leadership courses. And these are very expensive courses if you want to take them from other institutions. So we thought this will be a very good value for AKMG membership, for the members and for the membership experience. Just to give you an idea of what the course will look like, for example, we have very eminent faculty members. You'll all know Dr. Pradeepa Varki, a proud first Malayali president of Mayo Clinic Health System. She has kindly agreed to be part of the faculty. We have Dr. Larry Perkins, Brent Smith. Of course, you all know Dr. George Abraham, the president of the American College of Physicians. And you also, probably many of you will also know Dr. Suresh Aravind, who was the worldwide VP of Johnson & Johnson. Again, all of these are eminent faculty members in the healthcare leadership world. This is the course outline so that you can see what all topics will be covered. For example, strategic planning, effective leadership, entrepreneurship. We'll see how many different faculty members have generously donated their time for this course. So this will be heavily subsidized for AKMG members. We are opening it up for those who are interested outside AKMG at the regular price as well. The other program that we have launched is the career coaching one. Again, Dr. Marina has kindly agreed to be the lead for this program. So we'll be providing career coaching for our individuals. This is one of the latest update of the program that Dr. Sindu Pillai was mentioning from our flood relief program. Finally, we have completed that just this year. That the reason for the long delay is because in addition to the filters that we supplied, one other major project that was led by our past president, Dr. Thomas Matthew, was providing new houses for those who lost their houses there. And I'm happy to say that by this year, we've completed 38 homes for people who lost their houses related to that big flood in 2018. So finally, with the help of Rotary, we have completed now. That's nearly 40 homes that we were able to build for these people. And finally, this is in relation to the COVID relief project. Again, we have completed this. That's our last supply reaching Kerala. So you'll see it's a total of around 20 million masks that have reached Kerala. It's over $4.5 million worth of medical supplies that we were able to supply to Kerala. So, thanks to all of you. We are doing great work. Let's keep on doing the same. And thank you again for the opportunity to be, in the leadership of AKMG. It's a great honor for me. And thank you again, Sindhu Chechi. Thank you very much.
Thank you, Nigel, for that excellent speech. Thank you, as always. Now, we are going to have, like I said before, there will be CMA presentation. We have 2 talks, and we have a lot of very exciting cultural programs lined up for you. So please sit back, relax at your home, and enjoy the rest of the evening. We're going to start our cultural program with a song. This is Dr. Purnima Ashwani. She's a 31st batch Calicut Medical College. We have a lot of Calicut Medical College alumni here, we know. So this is Purnima from you could be proud of. She's practicing as an internist at San Francisco Bay Area, Oakland Veterans Clinic. She has 2 beautiful children, both doing pre-med, and she loves to sing. That is her extracurricular activity. And here is, I think she is in the group. She is attending the meeting. And Purnima for you. She's singing a song, lyrics by Puvachal Khadar, and the music is by Raghu Kumar from the movie, the famous movie of Mohanlal, Thalavattam, and is originally sung by Chitra Chechi. Purnima.
നമസ്കാരം, ഞാൻ ഡോക്ടർ പൂർണിമ അസ്വാനി, AKMG നോർത്തേൺ കാലിഫോർണിയ ചാപ്റ്ററിൽ നിന്നാണ്. ഇന്ന് ഞാൻ പാടാൻ പോകുന്ന ഗീതം സിനിമ താളവട്ടത്തിൽ KS ചിത്ര പാടിയ ഗീതമാണ്, പൊൻവീനെ എന്നുള്ളിൽ. മൗനം വാങ്ങൂ ജന്മങ്ങൾ പുൽകും ചെന്തളിരുകളോളം കന്യവാതികയിൽ മാനിനകളെ നോക്കി കായൽ കറുകളുമായി വരം നേടുന്നു, സ്വയംവരം കൊള്ളുന്നു. ഹേമന്തം പോലെ നവവാസന്തം പോലെ, ഹേമന്തം പോലെ നവവാസന്തം പോലെ, ലയം പോലെ മലർ പോലെ അരിയ ഹരിതഗിരിയിൽ പൊന്നീനെ എന്നുള്ളിൽ മൗനം വാങ്ങൂ. ജന്മങ്ങൾ പുൽകുന്നിൽ നാദം നൽകൂ. തൂതും പേരി നീകും മേഘം മണ്ണിൽ നിന്നും ഏതോ കാവ്യം ഹംസങ്ങൾ പാടുന്ന ഗീതം ഇനിയും ഇനിയും അരുളി പൊൻവീണെ എന്നുള്ളിൽ. ലാ 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 ലാ. Thank you everyone.
Thank you, Purnima. I know Purnima is in the crowd. Thank you so much for joining. And that was so amazing. That was nice rhythm and your smile was just amazing. Thank you, Purnima. Okay, next we are going to move forward with our Mohammed Rafi of AKMG. Does anyone know who that is? Well, he is also from Calicut Medical College. He's alumni of Calicut Medical College and he belongs to California. Here we have Dr. Ahmed Reza. He's an anesthesiologist practicing in Fresno, Central California. And he sang in our last convention, and I'm pretty sure he's coming to Toronto too. And here we have Reza singing Dilka Sonak Sas. I'm sorry, I don't know much about the words. His song is the movie is Ek Nari Do Roop, and music is by Ganesh and lyrics by Azad Popali. And here we have Reza singing. Gregory?
दिल का सोना साज तराना ढूंढेगा, दिल का सोना साज तराना ढूंढेगा, तेरे निगाहें नाज निशाना ढूंढेगा, मुझको मेरे बाद जमाना ढूंढेगा, दिल का सोना सांस तराना ढूंढेगा, तेरे निगाहें नाज निशाना ढूंढेगा, अरे मुझको मेरे बाद जमाना ढूंढेगा, दिल का सोना सांस तराना ढूंढेगा। लोग मेरे ख्वाबों को चुरा के ढालेंगे अफसानों में, मेरे दिल की आग भठेगी दुनिया के परवानों में, वक्त मेरे गीतों का खजाना ढूंढेगा, दिल का सोना सांस तराना ढूंढेगा, तेरे निगाहें नाज निशाना ढूंढेगा। साथी मुझको याद करेंगे भीगी भीगी शामों में, लेकिन एक मासूम सा दिल भी इन सारे हंगामों में चुप चुप के रोने का बहाना ढूंढेगा, दिल का सोना सांस तराना ढूंढेगा, फिर निगाहें नाज निशाना ढूंढेगा। आस का सूरज साथ रहेगा जब सांसों की राहों में गम के अंधेरे छट जाएंगे, मंजिल होगी बाहों में, प्यार धड़कते दिल का ठिकाना ढूंढेगा, दिल का सोना सांस तराना ढूंढेगा, फिर निगाहें नाज निशाना ढूंढेगा। अरे मुझको मेरे बाद जमाना ढूंढेगा, दिल का सोना सांस तराना ढूंढेगा।
Thank you, Rasa. See, I told you we have Mohammed Rafi right here in California. Thank you so much. That was just amazing. Thanks you. Thank you once again. Yes, we do have a lot of talent in California. And the next, you will know for the next program, we have Dr. Chino Manikarod and Dr. Salu John. They're both San Diego physicians. Chino is a hospitalist at Scripps Memorial Hospital, and Salu is an outpatient clinic psychiatrist at Kaiser Permanente in San Diego. They will be showing something very interesting. It's a short video exploring apnea. It's called, Chino named it as Emote Day Music. It's an expressive use of hand gestures and face using the pace and lyrics of music. It's an attempt to connect with the audience by emoting a familiar tune. Here we have Chino and Salu from San Diego, California.
അഗ്നിസാക്ഷിയായി നിലത്താലി ചാർത്തിയൻ ആദ്യാനുരാഗം ധന്യമാകും മന്ത്രകോടിയിൽ ഞാൻ മൂടി നിൽക്കവേ ആദ്യാഭിലാഷം സഫലമാകും നാലാളറിയെ കൈപിടിക്കും തിരുനാടകശാലയിൽ ചേർന്നു നിൽക്കും നാലാളറിയെ കൈപിടിക്കും തിരുനാടകശാലയിൽ
Thank you, Chino and Salu, and thank you for finding time in your busy schedule. Chino, I know you're very, very busy at Scripps Hospital with COVID going on the last month or so, and you found time to record this for us. Thank you so much. Next, it's my pleasure to invite our speaker, Dr. Vinod Pillai. He's a professor of hematology and hematopoietic cell transplantation at City of Hope. And I would like to invite Dr. Raju K. Pillai to introduce Vinod for the speech. Dr. Raju Pillai is Assistant Clinical Professor, Department of Pathology, Director of Molecular Pathology Core Laboratory at City of Hope. He's an alumni of Calicut Medical College, and he did his residency at All India Institute of Medical Science in Delhi and at University of Southern California, and fellowship in hematopathology and molecular pathology at the University of Pittsburgh. Dr. Pillai has a very strong academic and administrative background, and he's very actively involved in ongoing research with numerous publications. He's a principal investigator and sponsor in several research projects, including the Leukemia Research Foundation. Here we have Dr. Raju Pillai to introduce our speaker, Dr. Vinod Pillai. Raju.
Thank you, Sindhu. It's my pleasure to introduce Dr. Vinod Pillai, who is a professor of hematology and hematopoietic cell transplantation at City of Hope. Vinod was born and raised in Calicut. His father was the head of the Department of Plastic Surgery for several decades and trained generations of surgeons. So Vinod joined Calicut Medical College as part of the 29th batch. He was one of the best outgoing students. I had the great pleasure of knowing Vinod for about 35 years. So after graduating from Calicut, he got his MRCP, then moved to the US, residency in internal medicine at New York Methodist, followed by a fellowship in hematology oncology at USC. He then had a second fellowship in bone marrow transplantation at City of Hope, where he was faculty from 2003. In 2010, Dr. Pillai was appointed as the medical director of the bone marrow transplantation program at USC. After several years, he returned to City of Hope in 2014. His research is focused on acute leukemia and stem cell transplantation, also in bone marrow failures and autoimmune hematologic disorders. He is heavily involved in new drug development for acute leukemia. So as you may know, one of the major problems in the field of leukemia treatment is the inability of older patients to withstand cytotoxic chemotherapy. So people above 65, 70, it's really tough. So Dr. Pillai was the principal investigator of a major clinical trial conducted at City of Hope, which led to a new regimen for acute myeloid leukemia without chemotherapy. Many patients over 70 years old has been successfully treated, and this regimen is now widely used all over the world. He has authored over 150 papers in various well-regarded journals. He's a principal investigator for multiple clinical trials. And on a personal note, Vinod is married to Shija Pillai, also from Calicut Medical College, who is currently a professor of pathology at UCLA. They have two daughters. The older Priyanka is also a physician who is now following in her father's footsteps as an oncologist. So it's my pleasure to invite Dr. Vinod Pillai to enlighten us about the new advances in treatment of cancer.
Hello, everybody. Thank you for inviting me, Raju. Thank you for the kind introduction. It's my pleasure to be here today, and thank AKMG and Dr. Pillai for this invitation to present today. So I'm going to share my slides. Sindhu says slide sharing is disabled. Can you?
Yeah, you can try now, please.
Is everyone able to see the slides?
Yeah, good.
Can you see? So the next 30 minutes or so, I'm going to talk about the development of novel therapies for acute leukemia. This is an area where a lot of new development has happened in the last decade or so, particularly in the last 5 years. And as Raju mentioned, the challenges of treating acute leukemia, particularly for older adults. So I'm going to touch upon the new developments, particularly in the field of targeted therapies as well as immunologic-based therapies, which spare many patients from toxic chemotherapy. Those are my disclosures. So if you remember hematopoiesis, all blood cells arise from very primitive hematopoietic stem cells. These are the cells, a few of them in the bone marrow are present in everybody, and they give rise to all the blood cells via multiple progenitors at different stages of development. And broadly, they are divided into myeloid progenitors and lymphoid progenitors, and leukemias basically arise, the myeloid leukemias arise from the myeloid progenitors, and the lymphoid leukemias arise from the lymphocyte progenitors. So acute leukemia is one of the most dangerous of bone marrow cancers. They are characterized by a block in the differentiation. So if you see the previous slide, you can see there is an orderly differentiation of cells from the stem cell to the more mature cell in the blood. When you have acute leukemia, you have a block in this orderly development. And with that results in accumulation of very primitive progenitors in the bone marrow. So what it does is two things. One is it leads to bone marrow failure. There is not enough production of normal cells, but also these immature cells, often called blasts, can infiltrate other tissues. So traditionally, the treatments include conventional cytotoxic chemotherapy, which is basically agents which are targeted at cell division or cell metabolism, and also stem cell transplantation or bone marrow transplantation, where the patient's blood forming bone marrow as well as the immune system is replaced from a donor transplantation by donor stem cells. But one big problem is there is chemotherapy resistance, particularly in relapsed and refractory cases where these leukemias become, they evade the cytotoxic chemotherapy and become resistant to it. And this is a problem that often leads to the death of the patient. On the left side, you see a normal bone marrow. You have very orderly maturation. You have the progenitor cells at various stages of development. And on the right side is a marrow of a patient with acute leukemia. You see these large cells with very prominent nucleoli, very immature nucleus. That's the hallmark of acute leukemia. And there is this concept of leukemia stem cells. These are the few cells which avoid chemotherapy that leads to relapse. And this is what we try to target in treatment of leukemia to prevent relapse and achieve cure. So I'm going to talk briefly about three types of acute leukemia: the myeloid leukemias, which arise from the myeloid progenitors; the acute lymphoblastic leukemias that arise from the lymphoid part of the hematopoietic system. And there is a subtype of acute myeloid leukemia called acute promyelocytic leukemia. I take this is discussed separately because it is an area where there's a lot of, we can cure almost all of these patients. It used to be a deadly disease, almost always led to the death of the patient. Now, over 90% of the patients are cured. So acute myeloid leukemia is predominantly a disease of older adults. So the median age of diagnosis is 68. You can see from the graph that you have majority of the patients between ages of 65 and 85, which is a difficult population to treat because of their poor tolerability of chemotherapy as well as their comorbidities that often exist in these patients. So if you look at the 5-year survival in the bottom, you can see that from the 70s to now, it's been gradually going up, but it's nowhere close. I point out that the scale of the graph, the y-axis only goes up to 35%. So you have only about 35–40% of the patients surviving. And if you take the older patient population, the outlook is even more bleak. So that's our challenge with AML. And this is not a very updated slide, but you can see from age group of 65 to 80, the survival is dismal. There is under 10% of patients who are long-term survivors. Now, one thing about acute leukemias, particularly acute myeloid leukemia, is it's not one disease. You can see that it is a heterogeneous group of disorders with multiple genetic abnormalities, chromosomal translocations. They all lead to the same end result, which is block differentiation, increased proliferation. But it is, so these have, some of them have unique features. For example, on the left side, you can see TP53 mutant leukemias, which is a very difficult subset to treat because they carry mutations in some of the genes, in the TP53 gene, which confers resistance to chemotherapy. So if you look at the history of AML drug approvals, for a long time, almost 2 decades, 1960 to until about the 90s, you only basically had 2 drugs. You had daunorubicin and cytarabine, and these drugs were used in combination to treat. The problem is, again, you couldn't treat the older patient. But you can see on the right side, you have within the last 10 years or so, you have many different drugs that are approved. And some of these drugs are particularly drugs like venetoclax are targeted agents which target certain vulnerabilities of the leukemia cells. These are not conventional chemotherapy agents, so which makes it easier for patients to tolerate, and it can be applied to older patients. Many of these drugs are not curative, but they do allow patients to achieve remissions, and then these patients, many of them can be successfully cured with stem cell transplantation. So this is an example of a targeted therapy. IDH is, or isocitrate dehydrogenase, if you remember from the medical school days, is an enzyme that belongs to the tricarboxylic acid cycle. There's IDH1 and IDH2, and these mutations happen in about 20% of AML. What happens when you have an IDH mutation is that it leads to the production of what we call an oncometabolite, an abnormal metabolic product called 2-hydroxyglutarate, which blocks cell differentiation. So IDH inhibitors have been developed in the last 5 years. These can actually reverse this differentiation block, lead to remissions. And currently there are 2 agents that are approved, ivosidenib and inacidenib, targeting IDH1 and 2. And the remarkable thing about these agents is they're relatively non-toxic. So you can give it to older patients, you can give it to patients with a lot of comorbidities, and these can, in that subset of patients who carry this mutation, it can lead to remissions. Same thing with venetoclax, which is a BCL2 targeted agent. BCL2, initially described in B-cell lymphoma, that's why it's called BCL2, is a hallmark. Expression of BCL2 is a hallmark of leukemia stem cells. And venetoclax is an orally bioavailable drug. It's taken as a pill every day. It targets BCL2 and leads to apoptosis. BCL2 is an anti-apoptotic protein. So when you have high levels of BCL2, this allows cells to avoid apoptosis or cell death. And this drug is active in a variety of hematologic malignancies, but today we'll focus on its use in AML. So this is the natural process of apoptosis. On the left side, you have BCL2. What BCL2 does is it binds to these pro-apoptotic proteins that lead to programmed cell death. So it is protecting the cells from death by binding to these pro-apoptotic proteins. And that's a hallmark of cancer. When you have cancer, you have increase in anti-apoptotic proteins. On the right side, you see the drug venetoclax in red can displace these pro-apoptotic proteins. They then go to the mitochondria. They put holes in the mitochondrial membrane, release of cytochrome C, activation of caspases leading to cell death. That's supposed to happen in a very programmed manner in hematopoietic system. So there's ongoing cell death in the bone marrow and replacement of these cells by new progenitors from stem cells. But when you have leukemia, this process is deranged, and venetoclax is able to reverse this block in apoptosis and lead to apoptotic cell death of these leukemia cells. So that's a major advance in treating acute leukemia. Venetoclax is a drug which is broadly active in many different hematologic cancers. And this is a result of the trial Raju was mentioning. This is a pivotal trial combining venetoclax with another agent called azacitidine, which is a hypomethylating agent that was used as a single drug for older patients, and by itself does not have much activity. But you can see that in this trial, the combination of azacitidine with venetoclax more than doubled the complete remission rates. You have a 67% complete remission for the combination versus 28% remission rates for single agent azacitidine. And the survival is also prolonged by this combination. So this is a major development in this area. This allows older patients to be treated. It allows patients with other diseases, comorbidities, to be treated, and prolongs their survival, allows many of these patients to ultimately undergo stem cell transplantation, which we will talk about in a little bit. Now, switching gears to acute lymphoblastic leukemia. This is not as common as AML, but it's the commonest cancer in children. It's actually the single most common childhood cancer. About 75% of these are called B-cell ALL, others are from T cells. In areas like California or New York, these are much more common because of the larger Hispanic population. And it's also a molecularly heterogeneous disease. Its genetics vary between children and adults. Adults have bad prognostic abnormalities that lead to a poorer outcome. And history of ALL is very interesting. It goes back to about 1948 when the treatment of ALL was pioneered by Yella Subbarao and Sidney Farber. And he's a very under-recognized pioneer in this field. He's actually almost the father of modern chemotherapy. And Sidney Farber, who is well known for the Dana-Farber Cancer Institute in Boston, they both started treating patients with methotrexate, which is basically a synthesized folic acid antagonist. So it blocks DNA replication. So that was the beginning of ALL treatment. Then you had other newer drugs, similar drugs, anti-metabolites developed in the 50s, and steroids were found to be active in the 60s. Then you had vincristine, which is a microtubule inhibitor developed in the 60s. All of these drugs led to various chemotherapy combinations, which were very effective for children. So one would call 1960s to about 2010 as the era of chemotherapy for ALL. And that led to cure of a large number of children with this disease, but it did not work well for adults. Most of the adults eventually did relapse. In the 70s, there was development of stem cell transplantation or bone marrow transplantation. And in the 2000s, the major development was this development of tyrosine kinase inhibitors. You may all have heard about Gleevec or imatinib, which was developed for chronic myeloid leukemia, but a subset of patients with ALL, about 25% of adults have the same abnormality, the Philadelphia chromosome. And I'll show that how it works soon. That was a major advance, but it only applied to about 25% of the patients. Now, the big developments were in the last 10 years or so in the field of immunotherapy, where now a lot of patients who have relapsed disease or even upfront can be induced into remission or even cured with using agents that target immune system. So basically, they make your immune system fight the leukemia and lead to a cure, which is a remarkable development in this field. So on the left side, you can see the survival of children with ALL. Currently, over 90% of children can be cured with chemotherapy alone. But on the right side is the outcome for adults. These are young adults, 17 to 39. And the outcome is much poorer. You have a survival rate, a long-term survival rate of only about 50% at best. And if you look at the older patients in the bottom slide here, even worse. Similar to the older patient with AML, very few older adults typically survived this disease. And this is not very updated data, but this was the situation until recently. I mentioned about Philadelphia chromosome that is seen in 25% of adults. It's rare in children. It is what it is a reciprocal translocation. So it means that the chromosomal material is reciprocally exchanged between chromosomes 9 and 22, shown here in the bottom. And that leads to the formation of this fusion gene, which is called BCR-ABL. And what it does is BCR-ABL is a kinase that is always active. It does not need a ligand to be turned on. And that leads to downstream signaling and cell multiplication. Historically, pH positive ALL was considered a very high risk subset of ALL. Very few adults survived. But in the 2000s, there was development of first of Gleevec or imatinib, initially for CML, but then for these patients as well. And now we have multiple tyrosine kinase inhibitors and has markedly altered the prognosis of this disease. In the bottom right of the slide, you can see how they work. The BCR-ABL, as I mentioned, is a kinase. It leads to phosphorylation of downstream substrates at the tyrosine residues. You have an ATP binding pocket that is critical for transfer of the phosphate group, and imatinib can bind to that ATP binding site, block the phosphorylation of downstream targets. So this is a major advance, and this is not conventional chemotherapy. This is targeted therapy, which allowed many older patients to have less chemotherapy to be treated. You can see the impact it has made. On the left side is data from our SWOG studies from 1995 to 2000. The curve at the very bottom is the pH positive group. You have an 8% estimated 5-year survival. And you can see the difference in 2006 to 2011. This has gone up to about 50%, and with the addition of TKIs to conventional chemotherapy. And so that's has made a big impact for these older patients with pH positive ALL who don't tolerate chemotherapy very well. You can lighten the chemotherapy, use milder chemotherapy in combination with these tyrosine kinase inhibitors. But what's more remarkable in ALL is the development of immunologic therapies. So these can be of different types. You can have naked antibodies, which are basically antibodies directed against proteins on cell surface. You have immunoconjugates, which are basically chemotherapeutic agents attached to antibodies. The advantage of that is the antibody can be directed to a particular antigen that is seen on the cancer cell, so that the chemotherapeutic drug is delivered only to this cancer cell, thereby sparing other cells from toxicity. The more interesting concept is that of bispecific antibodies. So as you know, the antibody has a heavy chain and there are 2 light chains. So normally those 2 light chains are specific for the same antigen. In a bispecific antibody, one of those light chains will be targeted to the cancer cell. The other one will be targeted to your T cell. So what it does is brings your own T cells in proximity to your cancer cell, which has that antigen. So the 2 will form what we call an immunologic synapse, which leads to a cancer cell death by release of the cytotoxic granules from your T cells. So that's the concept of bispecific antibody. This has been remarkably effective in ALL. Now it's being developed for other diseases as well. Another major breakthrough, you may have heard about this, is the chimeric antigen receptor T cells, or CAR T cells. These are again T cells, your patient's own T cells. It can be from other donors as well, but mostly patient's own T cells modified using a virus to express what we call a chimeric antigen receptor. And I'll show you the structure in a minute. Again, using your T cells to repurpose them, to direct them against the cancer cell and lead to cell death. And lastly, one of the earliest treatments that cured leukemia was allogeneic stem cell transplantation. It is also a form of immunotherapy, because here you're using the donor's immune system to target the recipient's leukemia. So this is what blinatumomab, or BiTE CD19 bispecific antibody is. You can see one end of it is directed against CD3, which is an antigen protein expressed on surface of T cells, and the other end of that antibody is directed to CD19, which is a molecule, a surface molecule seen on immature B cells, including majority of the B-ALL. So when you treat these patients with blinatumomab, which is given as an infusion, you can create this kind of artificial binding of the two, your T cell to your cancer cell. In this case, it's acute leukemia cell. And that leads to release of these cytotoxic granules, which are normally present in the cytotoxic T cells, that will lead to death of the leukemia blast. So that's the concept of bispecific antibodies. This is CD19, which is seen in majority of the acute lymphoblastic leukemias. The advantage of CD19, it's not really expressed in many other tissues, so it spares an indiscriminate attack by these T cells to other organs. In other cases of other leukemias and other hematologic malignancies, we can target other antigens and achieve the same purpose. But this concept has been first pioneered in ALL, markedly effective in this disease. So here you have the outcomes of relapsed acute lymphoblastic leukemia. On the left side, you can see the randomized trial comparing blinatumomab with chemotherapy. You can see the median overall survival is almost double. It doesn't cure many patients. It's a segue to a curative therapy, usually stem cell transplantation. But you can see that it markedly it prolongs overall survival, and it induces much more remissions than conventional chemotherapy, which is not very effective once you have relapsed disease. Because by the reason these cells relapse is because they have developed resistance to conventional chemotherapy. So here is a study where you have the tyrosine kinase inhibitor I mentioned earlier, dasatinib, combined with blinatumomab, and now you can see the survival curve. It's short-term follow-up, but it's almost a bit 90%. So this is a chemotherapy-free regimen. So you have a targeted therapy and an immunotherapy combined, and to treat older adults, usually older adults with Philadelphia chromosome positive acute lymphoblastic leukemia. And you can see the progression in the improvement in outcomes. Initially, you had chemotherapy, which led to dismal outcomes, then addition of TKI, which improved it. But now you have two very effective treatments, relatively non-toxic, applicable to many adults with this disease. So this is one of the success stories in this field of acute lymphoblastic leukemia. Moving on to chimeric antigen receptor T cells. I mentioned these are usually from the patient. You collect their T cells by leukapheresis, very similar to the platelet donation procedure, or you spin down your blood, separate out the white cells, then you insert a gene which into the T cells using a lentivirus or a retrovirus. And what this gene does is it inserts this chimeric receptor into the T cell. The chimeric receptors are interesting. They have one end of that receptor is an antibody construct which binds to the leukemia cell, but the other end is a signaling molecule for T cells. So when the T cells recognize that leukemia cell with that particular antigen, they're going to proliferate. They're going to release cytotoxic molecules and lead to the death of the cancer cell. So after we generate these in the fact, now companies are making this commercially. You collect the blood from the patient, you ship it out to the company, they will generate the CAR T cells or ship it back to you. You infuse the CAR T cells to the patient, usually after some chemotherapy to ablate the immune system. And then these cells will expand in the patient's body and lead to killing of a cancer cell. This is a remarkable development in the field of acute leukemia, particularly acute lymphoblastic leukemia, now again being applied to other hematologic cancers like lymphoma. This is the structure of the chimeric receptor here. CD19 again is a very good molecule to target, because it's in the case of acute lymphoblastic leukemia, it's often almost always expressed. You have one end of these chimeric receptors is an antibody binding moiety targeting CD19. You have a linking area, then you have a co-stimulatory molecule that leads to activation of the T cells, and then you have a CD3 signaling end of the molecule. And what it does is once it binds CD19, expressing cells, these T cells are going to get activated. They're going to proliferate. They're going to release cytotoxic granules and kill the target cell. So what are the advantages of immunotherapy? One big advantage is, I mentioned chemotherapy resistance, particularly resistance of the leukemia stem cells. Immunotherapy, these methods do not care about chemotherapy resistance. It's a completely different mechanism of killing. So it is not relevant that the patient's leukemia is resistant to conventional chemotherapy. You can still kill that cell. Another advantage is that these are not dependent on leukemia genetics. So I showed you the IDH inhibitors before. Those can only be used for leukemias that have that particular mutation. In the case of immunotherapy, it does not matter what mutation the leukemia carries, it can broadly work. Another big advantage, it can be applied to patients who cannot receive conventional therapy, either due to age or comorbidities. And most of the side effects, immunotherapy, I have to emphasize, it is often very toxic therapy, but the side effects are short-term, unlike conventional chemotherapy, where you can have long-term morbidity just from the side effects of chemotherapy. Most of the side effects of immunotherapy are experienced within a short period of time after the treatment itself, and they're mostly, the management of that is improving, and they're mostly managed in the hospital with we know how to treat them now to avoid morbidity and mortality. What are the disadvantages of immunotherapy? The major disadvantage is you have to have a good target. So you have to have an antigen that is mostly limited to the leukemia cell to minimize off-target effects. Sometimes these cells are very smart. They can evade these immunotherapies by not expressing that antigen. We see sometimes relapses of ALL that are CD19 negative. So now you cannot kill them with the CD19 directed treatment. There may be immune exhaustion and sometimes lack of adequate T cells in this patient just by having the cancer, that environment of having cancer, these T cells are not sometimes functional, and that is a problem. Another big problem is the time required to make these cellular therapy products, particularly CAR T cells, because it takes about 2-3 weeks to make them. And if the leukemia is very aggressive, sometimes you cannot keep it under control until we get the product made. Short-term side effects can be severe and life-threatening. In early studies, there have been patients who died from these treatments. So it's not correct to say that these are non-toxic, but like I said, the toxicities are mostly around the time of infusion of these cells or these antibodies, and they are now managed much better. The biggest problem for immunotherapy or these novel therapies is the cost and the access. So these are currently remains available to a very small group of patients who can have access to it in tertiary care academic centers. And worldwide, to apply this is going to be very difficult due to the high cost and the manpower that is required to administer these and to manage these patients. But these treatments are highly effective. You can see CAR T cells for patients with ALL. This is data for 30 children with relapsed refractory ALL treated with CD19-directed autologous CAR cells. CAR T cells, 90% achieved remission. These are patients who have failed multiple treatments, and many had failed even stem cell transplantation. Half of those patients had relapsed after bone marrow transplant. And you have a 6-month event-free survival of 67%. It's unheard of before the advent of these therapies. Cytokine release syndrome, which is a major side effect of immunotherapy, including CAR T cells, occurred in about a third of the patient. And cytokine release syndrome is where your T cells are proliferating. They are releasing all these cytokines that can make the patient sick. Usually produces symptoms like fever, hypoxia, hypotension, and sometimes can even lead to death. The other major toxicity of these immunologic therapies is neurologic dysfunction. Again, not well understood, but that is a problem. It can lead to confusion, seizures, loss of, patients can be comatose for a period of time after these treatments, but usually patients will recover. Now, last part of my talk is going to talk about another success story, that is acute promyelocytic leukemia, which is a subset of AML, but is a unique type of leukemia. It comprises 10 to 15% of adult AML. Again, higher incidence in Hispanics, so we see it quite often in Los Angeles and California. Interestingly, a lot of these patients, usually when you think about leukemia, you have this concept of having a very high white cell count. These patients often have leukopenia, so it can be misleading. The typical presentation would be a young adult who comes to an emergency room with some unexplained bleed, and then you look at the coagulation parameters, the patient looks like they are in DIC. They have low fibrinogen, they have prolonged prothrombin time. So you have a bleeding disorder, you have mild leukopenia. So the fact that the patient has leukemia may often be overlooked because the blood findings per se are not that striking. And that's a big problem in this disease because many, and this is a disease of young people, many young patients will die before the diagnosis is established from very severe bleeding, particularly intracranial bleeding. Majority of these patients have a unique translocation, a chromosomal translocation between the retinoic acid receptor alpha and another gene called PML, or promyelocytic leukemia gene. That leads to a fusion protein, which I'll show you in a minute. This disease is sensitive to chemotherapy, but we have much better treatments now. Two agents have completely transformed the treatment of this disease. One is a vitamin A analog called retinoic acid. The other one is arsenic trioxide. So you can see bleeding like this from DIC, you have blasts, which have these prominent granule accumulations called hour rods. You can, in majority of patients, 95+% have this particular translocation between PML and RAR alpha. The retinoic acid receptor is involved in all the translocations seen in APL, or acute promyelocytic leukemia. Why that's important is that because of this translocation, these cells do not differentiate because it alters the differentiation program of these cells, and that can be reversed by retinoic acid analogs. So milestones in APL, 1957, it was first described, highly fatal disease, mortality was almost 100%, or it was 100% before daunorubicin was first identified as an active agent in the 70s, cured some patients who were fortunate not to have bad DIC and survived the initial treatment. In the 1980s, all-trans retinoic acid was introduced. Then you had combination of that with chemo, major breakthrough in 90s with arsenic trioxide, then the combination of atra and arsenic. And now I would say 95+% of APL is cured. Survival of patients in the pre-atra era, under 40%, current survival almost 100%. Early reports came from China of the use of all-trans retinoic acid in APL. Here are the structures of the analogs. You have the natural retinoids, and this is all-trans retinoic acid. What it does is you expose APL cells shown in the top left to atra or all-trans retinoic acid. They will start to differentiate. It can release that differentiation block that is caused by that translocation involving the retinoic acid receptor. Now these cells can mature in an orderly manner and form mature cells. So this was first observed, and then later on, again, Chinese made the observation that arsenic trioxide is highly active in this disease. It acts by multiple mechanisms. Interestingly, arsenic trioxide is one of the earliest proposed treatments for acute leukemia. It's even described in the Osler's textbook of medicine. Now we have a formulation of arsenic trioxide. It's basically the same drug, which is a highly active agent in this disease. You can see relapse APL, over 90% patients will get a molecular remission if you treat them with arsenic trioxide. And when you do a combination of atra with arsenic trioxide, again, this is a non-chemotherapy combination applicable to patients of all ages. It does much better than atra with chemotherapy. So currently that is the standard of care for most patients. I would say most of the patients with APL can be cured now without any chemotherapy. You just combine all-trans retinoic acid with arsenic trioxide, and that's again a remarkable success story in the field of acute leukemia. Lastly, I'll talk briefly about allogeneic stem cell transplant. Allogeneic transplantation is introduced in the 70s as a treatment for acute leukemia. was not very successful at that time due to a variety of reasons, mostly related to donor availability, related to complications from immunodeficiency, and also rejection, what we call graft versus host disease between the recipient and the donor. You leukapheresis the donor, collect the donor's white cells, you give the recipient chemotherapy or radiation, give the cells back, and then the cells lead to re-establishment of the donor hematopoiesis and donor immune system in the recipient. This is one of the original papers by the Nobel laureate Donald Thomas from Seattle. 100 patients with acute leukemia treated with total body radiation, which we still use to ablate the immune system and bone marrow in combination with chemotherapy, allogeneic marrow transplantation. Original methodology was using bone marrow harvest. Now majority of the patients get peripheral blood stem cells, which are mobilized with GCSF. This curve looks dismal, only about a 10% survival, but what is striking is that those 10% of the patients have a flat, like have a plateau in the curve, means they were cured of leukemia and they lived for a long time. So this was the proof of concept that this method will work and will lead to cure, but outcomes were dismal at that time. Now, currently, the problem with these smaller families is a lot of patients do not have any sibling donors. So we have to depend on the unrelated donor pool or the National Marrow Donor Program, and which is very effective for a lot of Caucasian patients of European ancestry, but for Indians or for Asians, it's often difficult. But the point here is that if you look at the curves of the unrelated donor transplant for AML, compare that to sibling donor, nowadays there is not that much of a difference. So for patients who can find a matched donor in the registry, there is not that much difference in outcome between a sibling or a matched unrelated donor. By the way, only about 25% of your siblings will be histocompatible to you. That's just the statistical probability of having a sibling donor. So if you just have one sibling, the chances are going to be small. So that was a big problem. And so the major advance in this field in the last decade or so has been what we call haploidentical stem cell transplant, which can provide a donor for almost every patient, because now we can use a 50% matched donor. So it could be a sibling who's statistically 50% of your siblings will be half matched. But you can also use your children, or you even use your parents. So this is a major advance. So traditionally, the graft sources who are matched sibling or mismatched siblings, matched unrelated donor, and sometimes we used umbilical cord blood, but that is a problem because adult patients, you don't have enough cells in cord blood to engraft. So that was not widely successful. But when you move to haploidentical transplant, then you have a much wider donor pool, sometimes first cousins, parents, children, siblings. So you have the possibility of a donor for almost every patient. And this was made possible by certain manipulations that you do in the patient, particularly the use of this drug cyclophosphamide in high doses after transplant to kill off the T cells. So it's basically a methodology of depleting the T cells from the patient, the donor's graft, so that the cells can engraft in your body. And this is data for haploidentical transplant for AML in first complete remission. You can see that the curves look almost similar to what I showed you earlier. So, which means that there is nowadays not a lot of difference between any of these donor sources. You can use a matched sibling, you can use a matched unrelated donor, or if that's not available, you can use a half-matched haploidentical donor. So that opens up this for a lot more patients, particularly of minorities, where finding a donor in the registry can be very difficult. So if you look at the trends in allogeneic transplant over the last 20 years or so, you can see that in the 2000s, so where the orange color is the patients. Two things have happened. One is that, like I said, the donor pool has expanded. Second thing is the age. There was a time when patients who were over 40 were not considered for transplant. Then it became 60, then it became 70. Now we routinely transplant patients over 70. Not every patient, but patients who are in good physical condition, have good organ function. That orange color is the number of patients over age 70 who are undergoing transplant. You can see that numbers, this is not a very updated curve, but you can see the numbers have been steadily increasing from around 2010 to the present. So allogeneic transplant is now available to more patients, to older patients, and that is a major advance. And that's my last slide, and I'll stop here, and thank you for your attention. Happy to take any questions in the chat.
Thank you very much, Dr. Pillai. I was indeed traveled through history of leukemia treatment. I still remember the time I spent in hematology during my medical school with the hematology team there. Probably my first exposure to personalized medicine. So as you are thinking about questions, we don't have much time, probably a couple of questions if anybody has, you're thinking of questions. Let me just show you the, okay, so that's the QR code. If you want to scan, please follow that. There's a short survey. It's going to test whether you were listening or not. And then you will get your CME credits after that. So before I go to the audience, Dr. Raju Pillai, any comments?
No, that was a great overview of the latest cutting edge therapies, and the advances now give us hope that, I remember in medical school, most patients we admitted with leukemia did not go back home. So compared to that, the 80%, 90% that we're seeing today, and at this rate, there is a lot of hope that most patients with leukemias and lymphomas in the next 10 years will be able to be cured.
Wonderful. It's indeed amazing to see the flat line instead of the dropping, survival. It's an amazing journey indeed. Dr. Pillai, one thing I've noticed, and when we talk about immunotherapy, always from a rheumatology perspective and immunology perspective, what comes to mind is, of course, the concept of immune activation, as is seen now in treatment of solid organ malignancy, especially melanoma, lung cancer, and all. Similar to the CAR T cell therapy, how is that field going on in the leukemia area?
So that is a problem. Like I said, it's often a misconception that immune therapies are very non-toxic, which is it's not. Immune therapies can have toxicities, particularly in the solid organ transplant. You have a different. Usually, the treatments are directed against this checkpoint inhibition. So there are drugs that release your T cells from natural inhibitory mechanisms. So you're basically creating a generalized autoimmune disease, and these T cells can cause pneumonitis, that can cause colitis. So in hematology, it's a little bit different concept. Those kind of checkpoint inhibitors have not been very effective in leukemias because the natural T cells are not very, very active. So when you talk about CAR T cells or the bispecific antibodies, the toxicity is limited to this condition called cytokine release syndrome, and that usually is a transient phenomenon because in these cells often do not persist very long. So they will do their job and they will eventually disappear. So the CRS, again, is managed by using antibodies directed against certain cytokines released by the T cells, including interleukin-6, and steroids. So that's more of a short-term problem. Neurotoxicity can be seen. Again, we don't completely understand it. It is also transient. So the diffuse autoimmunity that you see with solid organ immunotherapies is not typically a problem with the immune therapy for hematologic disease.
Great, thank you very much. Dr. Sindu Pillai, you can take over if any comments, and then.
Once again, thank you so much, Vinod, your busy schedule. Everybody enjoyed that highly informative talk, and thank you so much for speaking for us. Again, like Nigel said, there is a CME credit link there. You can all click that link and get your CME credits. Okay, now we are going to move over from a serious mood to a lighter mood. Music is a therapy for everything, as we know. So we have live music session from all the way from Arizona. Lakshmi Nair, she's going to be singing for us. Lakshmi, as you know, she's a fabulous singer. She was a featured artist singer for our last convention at Atlanta. She's actually from Kerala. She's from Guruvayur. She's a student of Carnatic music from Dr. Shyamala Vinod and Sri Srivalsan Menon. She's also a voice culture trainer and prepares music students for competitions and performances. She's also psychiatric nurse practitioner practicing in Arizona. She's performed in several stage shows, and she at the last convention at Atlanta, a lot of us who attended the convention had the opportunity to listen to her fabulous, enchanting music. And she has numerous independent music albums as well. So here we have Lakshmi singing for us. Lakshmi, take it away.
Hi, Chichi. Thank you so much for having me. It's always just a pleasure to be around AKMG folks because you guys are so awesome. That's something that I have to say. And I had the big fortune to experience your hospitality when I was in Atlanta. It was just a fantastic event, and I thoroughly enjoyed with my co-singer and the live orchestra and everything. So thank you so much for having me tonight as well. And just this is such an honor. So I'll be singing a few songs for you today, all classic ones that you will all enjoy. I'll start out by singing, and this is Goddess of Music, you know, Hindi music that we have lost in the past few days, Lata ji. So there's no beginning, you know, not remembering her. I'll start with one of her masterpiece songs, Lag Ja Gale. We all are familiar with the song. I don't really need to introduce the song, but the music was by Madan Mohan ji and lyrics by Raja Mehdi Ali Khan Saab. And it was, it came out in the 1964 hit Bollywood movie Wo Kaun Thi. And as you all know, it was starred by Sadhana ji and Manoj Kumar ji. So I'm going to go ahead and give a little try of this song. This is a masterpiece song. No one can ever make it up to what Lata ji has done to this song. But I'm going to give my humble trial. Thank you. लग जा गले की फिर हंसी रात हो न हो शायद फिर इस जन्म मुलाकात हो न हो लग जा गले की फिर हंसी शायद
we could have you sing for the whole evening, actually. We just don't have time. So amazing.
Thank you, Jetsi.
Amazing.
But
Keep going.
it's such a pleasure to just be able to even attempt these masterpiece songs in front of such an. I know you're all such amazing enthusiasts of music, and I know that you are such excellent, knowledgeable listeners.
Thank you. And AKMG is so proud to have you sing for us, and we just fortunate to have you sing for us. And thank you so much. And
Thank you.
we go to the next song, right?
Yeah, so I'll go to the next one. This is another masterpiece coming to our melody queen of Malayalam industry, Janaki Amma. I know that there is a crowd that really enjoys songs from 1960s and 70s, so I thought this would be a perfect choice for the audience that really enjoys Janaki Amma music. This is a beautiful hit from the movie Ambalaprava that got released in 1970. It was penned by Bhaskaran Mash, and the music is by legendary Babu Raj sir, Babuka. The actors in this movie are Sheelama and Prem Nasir sir. And I'll give an attempt at this song as well. This is Thane Thirinjum Maranjum for all Janaki Amma lovers and all enjoyers of the 1970s and 60s. So here we go. Just a second.
Wow. I mean, your audio system, I'm getting a lot of comments about your audio system. It's just so perfect. Your voice, your tone, and it's one of my favorite songs. And thank you so much for bringing back Janagi Amma to AKMG meeting. And it was just fantastic. And you're going to be coming back again, right? There is more
Yes.
songs coming up. Everybody stay back. Stay tuned. Lakshmi is coming back after a short break. Thank you, Lakshmi.
Thank you.
Okay, can I go in now?
Yes, please, Ravi. Thank you.
So that was an amazing performance, Lakshmi. Once again, a round of applause for her, although we can't hear you. Next, we have Sindu Pillai, our own Sindhu, doing a dance item. Sindhu doesn't need any introduction in this forum. She's a busy community pediatrician with a private practice and also embedded in a couple other hospital systems here. She wears multiple hats when it comes to hobbies and activities, as we all know: music, dance, drama, social and women's forums. The list goes on. She'll now present Mohiniyattam Padam, Swati Tirunal Kriti, Raga Aradhana, set to Aditalam, and choreographed by her guru, Kalema Mani Srimati Gopika Verma. So take it away, Sindhu.
श्री कुमार नगरलये श्री कुमार जितवरणे सुरवृन्दवैरे विनिवारणे मन्दगमनजिद वारणे सुरवृन्दवैरे विनिवारणे मन्दगमनजिद वारणे सुरवृन्दवैरे विनिवारणे मन्दगमनजिद वारणे सुरवृन्दवैरे विनिवारणे इन्दिरे भुवन कारणे कुरुपिन्ददन्ति किसलय मृदुचरणे इन्दिरे भुवन कारणे कुरुपिन्ददन्ति किसलय मृदुचरणे इन्दिरे भुवन कारणे कुरुविन्ददन्ति किसलय मृदुचरणे मन्दहासरुचिनिन्दिरेन्दु करकुन्दवृन्द मकरन्दबिन्दु मन्दहासरुचिनिन्दिरेन्दु करकुन्दवृन्द मकरन्दबिन्दु सन्दोह संवलित सुन्दराम्बुजास्ये जगदुवरसे श्री कुमार
Thank you so much, everyone for watching. And I am so fortunate to learn from Srimati Kalaimamani Gopika Verma, and I'm taking lessons from her. And I recently had a chance to attend a live class from her. I went to, in October, I was able to visit the palace and was able to see her and take classes from her. Thank you so much, and thinking about her right now. Okay, next we have, I think Lakshmi is ready for her next session.
Yes, but I have to say, what a beautiful piece that was. I mean, that's just, I can't imagine, and somebody commented that too. I can't imagine just learning so much, through online. It is a challenge to learn, especially a dance form online. It's very tough. So kudos to you and Gopika ma'am. So it's amazing job.
Thank you, Lakshmi.
Thank you. All right, so a couple more songs to entertain you guys. I will attempt a song that's very popular in Malayalam, Moham Kondu Njan, again Janaki Amma's song, by very, very melodious and always in the top list music director Johnson Masha. It came in the movie Shesham Karchil that was released in 1983 and starred the actress Menaka. So I'll give a little try of this song. I hope you enjoy. Thank you. മോഹം കൊണ്ടു ഞാൻ ദൂരേതോ ഈണം പൂത്തനാൾ മധു തേടി പോയി മോഹം കൊണ്ടു ഞാൻ ദൂരേതോ ഈണം പൂത്തനാൾ മധു തേടി പോയി നീലേ താഴെ തളിരാർന്നു പൂവനങ്ങൾ മോഹം കൊണ്ടു ഞാൻ ദൂരേതോ ഈണം പൂത്തനാൾ മധു തേടി പോയി കണ്ണിൽ കത്തും ദാഹം ഭാവജാലം പീലി നീട്ടി വർണ്ണങ്ങളാൽ മേലെ കതിർമാല കൈകൾ നീട്ടി കണ്ണിൽ കത്തും ദാഹം ഭാവജാലം പീലി നീട്ടി വർണ്ണങ്ങളാൽ മേലെ കതിർമാല കൈകൾ നീട്ടി സ്വർണ്ണത്തേരേറി ഞാൻ തങ്കത്തിങ്കൾ പോലെ ദൂരെ ആകാശ നക്ഷത്രപ്പൂക്കൾ തൻ തേരോട്ടം ആ മോഹം കൊണ്ടു ഞാൻ ദൂരേതോ ഈണം പൂത്തനാൾ മധു തേടി പോയി മണ്ണിൽ പൂക്കും നീളം രാഗഭാവം താലമേന്തി തുമ്പികളായി പാറി മനം തേടിയോയലാടി നാറും പുഞ്ചിരിപ്പൂവായി സ്വപ്നകഞ്ചുകം ചാർത്തി ആരും കാണാതെ നിന്നപ്പോൾ സംഗമ സായുജ്യം ആ മോഹം കൊണ്ടു ഞാൻ ദൂരേതോ ഈണം പൂത്തനാൾ മധു തേടി പോയി Thank you, everyone. I hope you
Thank
loved
you,
this
Lakshmi.
song.
Another favorite song of mine. Thank you.
Thank you. This is also one of
No
my.
words to say.
Yes,
Just
I know.
enjoy it.
Well, thank you. That goes to the song really,
Yes.
because ഇവരൊക്കെ വഴി വെച്ച് തന്നിട്ടുള്ള പാതയാണ് നമ്മളെല്ലാവരും just listen to it repeatedly to let music infuse in you.
Yes.
So Just,
One of
just
the classic. And thank you so much for singing all these classic songs for us.
Thank you. Yes, thank you. And this is such an important crowd. I mean, this is a very knowledgeable crowd in music, not just in, science. You're all such amazingly knowledgeable crowd in music, because I know that, very well firsthand. So I have to be, well prepared. Here we go. So this is one last song that I'll be performing for you today. This is a peppy one. I would like to leave the stage on a very peppy note. This is Baho Mein Chali Aao. This came in this amazing 1973 hit Anamika, and I know you all probably love this movie and just the music in itself in this. Musician behind this is R.D. Burman sir, and it was sung again by Lataji. So I'm glad to be able to sing two of my, goddesses in music today, Lataji and Janaki Amma. That's what I chose today, and they're both my idols in music. So here's Baho Mein Chali Aao for you. बाहों में चले आओ, बाहों में चले आओ, हो हमसे सनम क्या पर्दा, हो हमसे सनम क्या पर्दा, ये आज तक नहीं मिलन Thank you, everyone. And thank you so much again for having me and just giving me this beautiful stage and being such wonderful audience, even online. So thank you.
Thank you, Lakshmi. Thank you very much on behalf of AKMG. And look forward to seeing you in person sometime soon in another AKMG event.
Yes, so do I. Thank you. Thank you so much, everyone.
Wonderful, wonderful. Thank you again and good night.
Thank you. Good night.
Okay, so we originally planned a little bit of an interaction, a 10-minute interaction, but unfortunately we're running short of time. So I'll just take this opportunity to just bring on, highlight the amazing EC of AKMG that's here in the crowd today. I think Deepu, our secretary treasurer, had to leave. We got called to the hospital, but we have our wonderful president-elect Geeta Nair, who you already saw her amazing MC abilities in our last program. She's always there ready. Thank you. And the amazing dancer and MC and singer and our VP, Dr. Sindu Pillai. Thank you. Thank you very much. Where is our immediate past president, Dr. Subra Bhatt? Okay, if we can highlight him as well. Thank you all for being a great team for AKMG, and look at what we are able to accomplish, all of us together. Okay, so since we don't have time for interaction, but I would like to bring on stage one person in particular, our chair, the brand new chair of Young AKMG, Dr. Teresa Verghese. Teresa, I believe you have some exciting news for our AKMG members today.
I do. Can everyone hear me?
Yes.
Okay, perfect. So thank you, Dr. Nigel. I'm Teresa Verghese. I'm the new chair of Young AKMG, which is the medical students, residents, and fellows in training. So before I introduce our initiative, I just want to encourage everyone, if you know of any medical students, residents, fellows of Keralite origin, tell them to join AKMG, join our group. We have a lot of opportunities, and it's a great networking opportunity for young physicians like us as well. Now, coming to our exciting new opportunity initiative, over the past 2 weeks, I was working with Dr. Nigel and different manufacturers and distributors to finally get a sample order for our AKMG merchandise. So you're looking at our AKMG merchandise. We spoke about this at the lounge meetings last year, where we wanted, as AKMG grew, we wanted our visibility to grow as well. And we wanted to have a nice sweater or something we could wear at the conference, but also, share with our family, like our kids and our grandkids, to show not only the community of physicians we come from, but the philanthropic and humanitarian work that we've done as an organization. So I'm happy to present our sample order. Right now we have 3 sweaters. We also have coffee mugs coming for the convention. And so we have this navy blue crew neck sweatshirt with the logo in the front. That's like a big logo. We also have the option of a light blue sweater, which is true to our logo colors, and then the small logo on the left chest. And then we also have hoodies with the blue and the gold embroidery. So what I wanted to let everyone know is in the upcoming week, Dr. Nigel and the team will be working on an order form and a link. So you will be able to order your own sweatshirts based on your preference, whether you like the navy blue style or if you like the light blue style. And I'm hoping that, it's something that everyone can enjoy and share and use for a long time. I'd be happy to answer any questions about AKMG merch, but also this is a very tough time for us young medical students and residents as we're applying for the match. We appreciate your support through this past year, through the interview prep and the opportunities in research and observerships. So as we match this cycle, please keep us in your thoughts. And if you know of any residency openings in internal medicine or family medicine, please reach out to any of us on the WhatsApp group, post it in WhatsApp. Reach out to me. I'd be happy to share that with everyone else. Thank you all for your time and attention, and I hope you can enjoy this new product.
Thank you, Teresa. You're such an amazing leader, and we are so fortunate to have you head our Young AKMG group. Continue the good work. Of course, as a leader, you brought the Young AKMG group together. I'm sure you'll all prosper and have a bright future along with AKMG. Thank you again, Teresa.
Thank you, everyone.
Okay, I think I can, unless I don't see any hands up, if anybody wants to make any comment. If not, let me hand it back to Dr. Sindu Pillai to continue the program so we can finish on time. Thank you.
Thank you, Nigel. Thank you, Teresa, for coming over and speaking for us. We have a lot of enthusiastic youngsters in California too. So please get in touch, stay connected, and that's what AKMG is all about. Okay, so now we're going to move over to the next segment of programs. Please don't leave. We have more informative talk. We have more music, more dance. So it's coming up. So please stay tuned. So our next program in our list is another dance. It's the Bharatanatyam. And it's going to be performed by Dr. Maya Manoharan. She's again from California. She practices OBGYN in Manteca, California, Northern California. And with her husband, who's a hospitalist, and she has 2 young sons. In her downtime, she likes to travel, gardening, and she dabbled in the arts, which is particularly in Bharatanatyam. And here we have Dr. Maya Manoharan with her Bharatanatyam Padam.
ஆனந்த பஞ்சபூதங்கள் முழங்க பஞ்சபூதங்கள் முழங்க பஞ்சபூதங்கள் முழங்க பஞ்சபூதங்கள் முழங்க பஞ்சபூதங்கள் முழங்க பஞ்சபூதங்கள் முழங்க கணங்கள் பாய்ந்து தாடம் வழங்க பஞ்சபூதங்கள் முழங்க கணங்கள் ஐந்து தோழிலும் தொடங்க காலம் அதித பூவிகள் பொருங்க ஐந்து தோழிலும் தொடங்க காலம் அதித பூவிகள் பொருங்க தஞ்சம் தஞ்சவேத அன்பர் குறைகிட தஞ்சம் தஞ்சவேத அன்பர் குறைகிட தந்தோம் தந்தோம் தாகிட தகதீம் ஜன தந்தோம் தந்தோம் தாகிட தகதீம் ஜனகாரி தனித பத மக கரி ததிக பத மக பத சாரி தனித பத மக கரி ததிக பத மக பத ததிக பரிக சரி தத பத ததிக மாஜரி சரி தப மக ததிக பத ஆனந்த நதனம் ஆடின பராசக்தி நடனம் ஆடினாள் சச்சிதானந்த நடனம் ஆடினாள் ஆனந்த நடனம்
Wow, what a beautiful Ananda Nadanam. It was purely Ananda Nadanam, Maya. That was so beautiful. And she's an obstetrician and she was very busy. And I thank her so much for finding time to record this for us. And thank you, Maya. Next, we have a musical segment. It's going to be, the first one is by Nevin Gregory, the son of Susan and Gregory. And we all had the opportunity to listen to him at the Atlanta convention. He's just amazing. He's senior in high school. He has extensive training in Hindustani, Carnatic, and Western vocal, along with violin and piano since age 4. He's also a music composer. He's a senior in high school. He's a music composer that won a gold award in the international composition competition. He's currently in the Emory Youth Symphony Orchestra. And he's going to be singing the song from the famous movie, His Highness Abdullah. Does anybody know which that song is? Make a guess. The Pramadavanam song, the certain most popular song. Music is by Ravindran Master and lyrics is by Sri Kaidapram. So here we have Nevin Gregory.
പ്രമദവനം വീണ്ടും ഋതുരാഗം ചൂടി പ്രമദവനം വീണ്ടും ഋതുരാഗം ചൂടി ശുഭസായാനം ശുഭസായാനം പോലെ തെളിദീപം കളിനിഴലിൻ കൈക്കൊമ്പിൽ നിറയുമ്പോൾ പ്രമദവനം വീണ്ടും ഋതുരാഗം ചൂടി ഏതേതോ കഥയിൽ സരയുവിലൊരു ചുടുമീ നീർക്കനമായി ഞാൻ ഏതേതോ കഥയിൽ സരയുവിലൊരു ചുടുമീ നീർക്കനമായി ഞാൻ കവിയുടെ ഗാനരസാമൃത ലഹരിയിലൊരു നവകണക കിരീടമിതണിയുമ്പോൾ ഇങ്ങിതാ പ്രമദവനം വീണ്ടും ഋതുരാഗം ചൂടി മഹിമ തഴുകിയ മുരളിയിൽ ഒരു യുഗ സംക്രമ ഗീതയുണർത്തുമ്പോൾ ഇന്നിതാ പ്രമദവനം വീണ്ടും ഋതുരാഗം ചൂടി പ്രമദവനം വീണ്ടും ഋതുരാഗം ചൂടി ശുഭസായാനം പോലെ ശുഭസായാനം പോലെ തെളിദീപം കളിനിഴലിൻ കൈക്കൊമ്പിൽ നിറയുമ്പോൾ പ്രമദവനം വീണ്ടും ഋതുരാഗം ചൂടി
Thank you so much, Nevin. That was just amazing. It's a difficult song, and you did a great job on singing that certain song. Thank you. And now we have Nevin's sister, Neha, singing for us. Neha is a sophomore at University of Georgia, majoring in music theory and psychology, also in the pre-med track. She has been learning Hindustani, Carnatic, and Western vocal along with violin since age 5. Neha is going to be singing the famous song Mauna Sarovaram, sung by Chitra Chechi, from the movie Savitham, and music is Johnson Master and lyrics by Kaidapram again. Here is Neha for us. that was so beautiful. What a beautiful rendition you have it. We were able to hear again, and she did such a great job also at the last convention. And I'm sure we are going to have more of those sessions at Toronto. So looking forward to that, Neha. Thank you so much for singing for us. Next, we have another song. It's going to be a Hindi song. It's going to be by Dr. B.N. Sri Kumar. He's a cardiologist at Baptist Health Deaconess System in Madisonville, Kentucky. And he's going to be singing a Kishore Kumar song. Dr. Sri.
Hello, everybody. The song that I'm going to sing is from the film Manzil. Arguably, it's one of the most popular songs of Kishore Kumar. Hope you all enjoy it. Let's get started.
रिमझिम गिरे सावन सुलग सुलग जाए मन भीगे आज इस मौसम में लगी कैसी ये अगन रिमझिम गिरे सावन सुलग सुलग जाए मन भीगे आज इस मौसम में लगी कैसी ये अगन रिमझिम गिरे सावन जब घुंघरुओं सी बजती है बूंदे हर माह हमारे पलके नमूंदे जब घुंघरुओं सी बजती है बूंदे हर माह हमारे पलके नमूंदे कैसे देखे सपने नयन सुलग सुलग जाए मन भीगे आज इस मौसम में लगी कैसी ये अगन रिमझिम गिरे सावन महफिल में कैसे कह दे किसी से दिल बंध रहा है किस अजनबी से महफिल में कैसे कह दे किसी से दिल बंध रहा अजनबी से हाय करे अब क्या जतन सुलग सुलग जाए मन भीगे आज इस मौसम में लगी कैसी ये अगन रिमझिम गिरे सावन सुलग सुलग जाए मन भीगे आज इस मौसम में लगी कैसी ये अगन रिमझिम गिरे सावन
Thank you.
Thank you so much, Dr. Sri, for singing that evergreen melody. That was such a nostalgic song for all of us, I'm sure. Next, we have our next next talk by Dr. Rajat Agrawal. He is an ophthalmologist and he's a founder and president and CEO of Retina Global. And I would like to invite at this time my dear friend, Dr. Ravi Raghavan. Ravi is a professor in neuropathology at Loma Linda Nolinda Medical Center, a clinical professor at School of Medicine, UC Riverside. And he's my right hand. He has been such a great help for me to put this together. And here is Ravi for you to introduce Dr. Agrawal. Thank you.
Unmute yourself, Ravi.
Ravi, please unmute.
Can you hear me now? Yeah. Thanks again. Welcome once again to everyone, both our existing members in California as well as the AKMG board members, etc. A big hand to the audio video team here. They're doing a wonderful job. It's my pleasure to introduce our second speaker of the evening, Dr. Rajat Agrawal. As Sindhu just mentioned, Dr. Agrawal is a founder, president, and CEO of Retina Global, an international nonprofit, as well as vice president at Resolute Incorporated, clinical development of the ophthalmology lead there. To give some background, he started as a retinal surgeon at Shankar Nethralaya in Chennai and was there for 7 years. And then he moved over to Hong Kong and Caribbean, providing retinal services there. From 2003 onwards, I guess this high point of his career, I would think, he helped invent and develop an artificial retinal implant, also called a bionic eye, at USC, University of Southern California, Keck School of Medicine, the Doheny Institute. The implant has been approved by the FDA in 2013 and is after trials in Europe and USA. From 2012 onwards, I would say his legacy work, he initiated a nonprofit called Retina Global, which provides retinal care to patients in underserved areas of the world, with help from volunteer retina specialists in these areas, as well as the industry. The organization continues to provide services in Central, South America, and in Africa. From 2020-21 onwards, and he'll tell us a bit more about it after his talk, perhaps, he started the Orange County Eye Project, organizing monthly eye clinics to provide eye care to the underserved population within the Orange County area, as well as in the Bay Area and Indian reservations, etc. He also consults for various companies and is on the advisory board of companies as well. Rajat and I go back a long way. His wife Renuka was our resident at Loma Linda, and that's how we got acquainted. We have remained good friends ever since. So Rajat, it's over to you.
Thank you, Ravi. Can you hear me well?
Right. Yes. Yes.
I'm trying to share my screen, but it says it's disabled. Okay, thanks. All right. Can you guys see the screen, the PowerPoint presentation?
Yeah. Yes, we can.
All right,
yes.
Thank you. So first of all, thanks, Ravi, for that introduction. And I was about to mention the fact that, I've known you since the initial time frame when I used to call you Dr. Raghavan, to now being referring to you as Ravi. So it's been a long journey. And as you mentioned, he was a faculty to my wife when she underwent residency at Loma Linda before moving on. And obviously we've been in touch since. So thank you, Ravi. Obviously this my opportunity for me to come and speak to all of you has happened because of this connection with Ravi. And I'd also like to thank Dr. Pillai and Dr. Haroon from the AKMG in giving me this opportunity. So thank you so much. I'm going to be speaking on diabetic retinopathy. I just, by the way, I just heard some beautiful songs. I was waiting for my talk. I'm amazed at the capabilities of people over and beyond medicine, so which is huge. I'm a bathroom singer, and I would never speak or sing like this in public. But anyway, that was great, especially the last song, Dr. Sri Kumar. That was really amazing. I'm going to be speaking on diabetic retinopathy and and diabetic macular edema, which is a topic which is close to my heart, as well as talk a little bit about the current standard of care and the unmet need in the space at this point of time. The topic is going to cover these basic areas. I'm going to talk a little bit about the prevalence of diabetes in general, and I'm sure all of you are experts at this, and some of you potentially treat patients on a day-to-day basis. I'm going to delve a little bit deeper into retinopathy and macular edema, discuss a little bit about current standard of care and future treatments that are likely to come pretty soon. Two topics that are pretty interesting. One is artificial intelligence, which is currently in use in diabetic retinopathy in the US and around the world. And lastly, Ravi asked me to speak a little bit about the unmet need in regards to the nonprofit work that I do. So I'm going to talk about that. I'm going to try and speed through these slides. It's pretty late for some of you, so bear with me for a little bit. Again, we all know that diabetes is affecting pretty much every region of the world. Numbers are constantly increasing. People have talked about, looking at numbers potentially in the next 10, 20 years. And all of that, as the image here shows, which is from the International Diabetes Federation, the arrows seem to be going up crazily and significantly, both not only in Northern America, but also in Asia, in Africa, and in South America. And the cost of treating these patients over the year is significant. As we see the numbers in Northern American continent, huge, billions of dollars. The same applies to any other region that we look at, especially also looking at India, which is the country that we are all connected with. Numbers are unfortunately keep on increasing. In terms of projections, the numbers are likely to double, as we go along from 2010 onwards to 2050. And unfortunately, in terms of the subset of population that is going to get affected, Hispanic Americans are likely to have a significant increase, almost threefold compared to African Americans and Asian Americans, as well as white Americans. Just wanted to touch base on India, which is, like I said, we are all connected with. We've been hearing the word pandemic thrown around for the last 2 years. But we also have been hearing about the word pandemic in regards to diabetes in India. The number of patients with diabetes in India is significant. And again, it keeps on increasing. We actually take a lead over China in terms of the number of patients with diabetes in the country. A significant part about the problem in India is the number of patients with unknown diabetes is significant. Again, this is more so in the rural areas because of lack of access to specialists. Also, the fact that the features of the disease in diabetes, and again, this is pretty, probably everybody knows about it, but the features of the disease of diabetes in the country, in India, is different from what we see here. And again, the changing lifestyle of people in India is also causing a major problem in terms of the numbers increase. A historical fact, diabetes has been known to us for many years, 5,000 years apparently, in fact, and Sushruta was considered the father of medicine in India. There's a description about diabetes in his treatise about sweet urine in a patient with diabetes. Interesting. Importantly, diabetic retinopathy is a leading cause of visual impairment in adults, between 20 and 65 years of age. Almost 1/3 of those patients with diabetes will develop diabetic retinopathy in time. And as the duration of diabetes in a patient increases, the chance of development of diabetic retinopathy goes higher. And so in majority of the patients with diabetes, with the duration touching about 20 years or so, they are likely to develop diabetic retinopathy. Excuse me. An important thing that we need to remember about diabetic retinopathy and macular edema is that if we screen patients on a regular basis, if we are able to treat them at the right time, we can potentially prevent visual impairment in these patients, as we all know. So one of the biggest problems that we face, both within the US and around the world, is that patients do not come in at the right time for treatment. And unfortunately, when they come in, it's a little too late for ophthalmologists to try and get the vision back to where they were at the beginning. Almost 1/3 of the patients with diabetic retinopathy are likely to develop diabetic macular edema. The number is actually increasing now. In terms of where things stand in pathogenesis of diabetic retinopathy, again, this is capillary basal membrane thickening that happens in the vascular level, which leads to hemorrhage, fibrosis, and new vascularization. And then we also see what we describe in histopathology as a classic sign where there's a loss of microvascular intramural pericytes. And that leads to all the issues that we see clinically, which is microaneurysms, which are the earliest sign of diabetic retinopathy in patients. And that again leads to various other signs that I will describe in a little bit in the next few slides. One of the points about systemic factors in relation to diabetic retinopathy is pretty much, all the significant factors increase the chance and effect of diabetic retinopathy, including puberty, hypertension, nephropathy, pregnancy, and hyperglycemia. Genetic factors are now being considered to be an equal part in terms of increasing the likelihood of diabetic retinopathy, while two factors in the eye, glaucoma and myopia, have been known not to have increased chances of diabetic, DR. In fact, they reduce the chances in some ways. So if anybody has myopia or glaucoma, the chance of DR development in those patients is less. In terms of description of stages, we usually describe diabetic retinopathy into non-proliferative and proliferative. And there are three subdivisions to the non-proliferative part, which is mild, moderate, and severe. And severe is the one that we normally look at. And in this image here, the third image on the top, which is the severe part where you see all those blood and exudation. Usually these patients have high-risk characteristics as we describe as 4-2-1 rule, which if present, those patients require treatment early on to prevent progression and further loss of vision. In the proliferative category, if patients have neovascularization happening on the retina or any bleeding that is seen, hemorrhage on the surface or in the vitreous cavity, those patients require injections or laser treatment, or in some cases, even surgical intervention to try and correct the problems. One of the aspects of visual impairment in patients with diabetic retinopathy is macular edema, which is swelling in the macula. And as you see on an OCT image on the bottom right of this, on the right side, the bottom image, which is where you see all those vacuole formation in the retina. And this is the reason why patients have significant visual impairment. And that is a requirement for treatment as soon as possible. Some of the investigations we tackle, one of the standard indication investigation that we have now, which is pretty much in every clinic in retina and eye clinic around the world, is ocular coherence tomography, or OCT for short, which looks at the retina at a very high resolution microscopic level, almost at a 1 micron level. And the image in the middle of the right side, you see a histopathological picture of the retina on the top, the colored one. And the bottom one is a black and white image on an OCT. And you can imagine that the OCT image is almost a live representation of a histopathology image of the retina. So this is what we can actually see in a patient when the patient is in the clinic, and potentially be able to diagnose conditions early on and be able to treat them if required. Other two investigative modalities that we have is fluorescein angiogram to figure out patients with non-perfusion areas or leakages in the retina, and that will require patients to undergo injections or laser treatment. And if patients have any vitreous hemorrhage or cataracts, those patients require ultrasound exams. Obviously, as we know, diabetes affects various aspects of the human body, and when a patient has diabetes, he or she has to undergo treatment from various specialties, and everybody has to work in tandem to try and make sure that the patient has the best outcome in terms of not only vision, but also other aspects of what diabetes affects in the body. Going through some of the studies, there are some classical studies that we describe and we talk about when we look at how we treat patients now. And this was the first study, diabetic retinopathy study, that actually started off, which gave us the impression as to which is the best way to treat these patients coming into the clinic. Before, there were various types of laser machines that were used. One of them was argon laser, the other one was xenon, which is pretty old. And this study pretty much defined that laser treatment to patients potentially reduces the risk of visual impairment in time. And that is how, like I said, these are the classical studies that we kind of refer to every time in the clinic in terms of the fact that they have managed to define how we treat patients. The other important study is the Diabetes Control and Complications Trial, the DCCT trial, which defined the fact that intensive blood sugar control dramatically reduces or delays or even prevents diabetic retinopathy in some cases. Hugely important, because before that, people used to say that you should not be controlling glucose levels extensively in patients because that may cause various issues. But this study showed definitively with evidence that we have to control blood sugar at an intensive level to try and control the disease progression. And the benefit extends over years if the patients control blood sugars on a regular basis. And also, if the patient has had a bad history or poor control of blood sugar previously, lowering of blood pressure definitely will help the patient in the present context and also in the future. Early treatment of DR study or the ETDRS study is actually a very important study from a clinical trial perspective, because it gave us that chart that we see on the left of the slide. I'm sure everybody's gone to an eye clinic and they've seen the Snellen's chart, where you read those letters to figure out your vision. But this is the chart that we currently use in clinical studies to define the patient, so that patient's vision can be compared from one clinic to another. The Snellen chart has been found not to be as effective in terms of comparison of vision between patients at different time points and different locations. And one of the things that EDTR has defined was the clinically significant macular edema, the definition of patients with CSME where patients definitely require treatment. And this study potentially looked at patients being treated with laser, but now we treat all these patients with injections, intravitreal anti-VEGF injections. So what are the treatment options we have? So patients with early, mild, or moderate NPDR, we don't usually treat them. We observe them. Some of these patients can be called early, but usually about 6 months. Any patient with severe NPDR usually has a high chance of development into PDR within a year. So either those patients require close observation, and if they cannot, then usually an anti-VEGF injection is given in the eye of those patients to try and prevent any disease progression in time. High-risk patients of proliferative diabetic retinopathy can undergo injections or laser treatment. And in cases where they have bleeding or vitreous hemorrhage in the eye or traction retinal detachment, they require vitrectomy surgeries. So what are the current treatments we have at this point of time? And since 2006, we have pretty much switched from laser treatment to anti-VEGF injections, starting with Lucentis, which got approval in 2006. Followed by Eylea from Regeneron. And then, in fact, Vabysmo, which is the number 4 in that category, was just approved last month, which has increased the frequency or actually in terms of durability, so that we have to give less injections to patients now compared to what we gave with Lucentis and Eylea. One thing that I want to point out is, I'm sure people who have come across patients with diabetic retinopathy and likely to get treatment, you may have heard about the fact that some patients do get Avastin injection. Avastin is off-label. It has never been approved by the FDA. And as we all know, this is used in oncology. But we found in a large NIH-funded study that Avastin was actually almost similar to Lucentis and Eylea in terms of outcomes. And so Avastin actually is used almost 50% in clinics at this point of time. Laser, as I mentioned, was previously used. In certain category of patients, we do use them, but it's not as commonly used. And in patients who have chronicity of the disease, especially in diabetic macular edema, those patients tend to undergo corticosteroid injections, or in some cases, devices are implanted into those patients. One aspect that has brought technology into the realm of consultation from an ophthalmic perspective is teleophthalmology or telemedicine. And in fact, in India, it is actually being used in a significant way in large eye institutions in Hyderabad and in Coimbatore, which allows patients in remote areas to be seen or at least given an opinion of by a retina specialist sitting in the institution itself, being told whether the patient needs to come into the clinic or he can or she can then come back in a few months for a review. The biggest problem in terms of the remoteness is the fact that you can't treat these patients. And I'll describe a little bit also from the aspects of artificial intelligence, why this could be a problem. In terms of future treatments for DME or DR, currently, most of the diseases that we have, they are all disease stabilizing. So, we give injections, we wait for a disease to recur, fluid to start collect again, and then we go back and inject those patients. So we don't really have a treatment at this point that potentially modifies the disease. And that's what we are hoping for in the next few years to come by. One of the important disease modifying treatment potentially would be gene therapy, which will likely to be a one-time therapy. So we don't really know at this point how it will pan out in terms of patients, but it definitely has shown in early stage studies that it can define and change the disease of diabetic retinopathy and macular edema. I'm involved in a oral medication development at this point of time with a company up in the Bay Area. And one of the problems with injections, as we all know, is the painful part of things in terms of getting injections. Also, we are not able to give injections in earlier stage disease or as a prophylactic, and patient compliance is an issue. So oral medications potentially will address all those things and be able to, provide patients with some parameters. One aspect that that has definitely changed some aspects of ophthalmology care, especially in relation to diabetic retinopathy, is artificial intelligence. In fact, in diabetic retinopathy was the first FDA-approved AI system that has been used in medicine. And what it does is it tells the patient whether the patient requires to see a consult with a specialist, or patient can go home and come back after a few months. And this is reimbursable at this point with CMS and other payers. Importantly, this allows patients, clinicians to kind of triage patients in high traffic areas, so that patients who don't really need to come to see the physician can then go back and come as and when they're advised to. Also in patients who live in underserved areas where physicians are not able to access those patients, these systems definitely make a huge difference. Just to mention, as Retina Global, as a nonprofit that Ravi was describing about, we are working in South America and Central America as well as in Africa. And we, in fact, did a clinical study utilizing AI from a company in New Mexico. And with that camera, the handheld camera, which was provided by a company out of Ohio, we did a diabetic retinopathy clinical study of 1,000 patients within 3 months. As you can imagine, the number of patients in these underserved areas is significant. So we could recruit about 1,000 patients within 3 months and managed to showcase the fact that this approach can potentially make a difference in patients in real time, in the real world scenario. We are also conducting a currently ongoing study, artificial intelligence using diabetic retinopathy as an indication in Brazil, in the smallest state, in fact, of Brazil, called Sergipe, where we are screening all patients with diabetes and providing them treatment at this point via Retina Global's efforts there. One of the big problems is, as I mentioned earlier, to begin with, unmet need. So there are areas significantly around the world, and importantly within the US, where patients do not get access to care. And one of which, as Ravi initially mentioned, the Orange County AI project. So Orange County is considered to be, people don't really understand that there are patients who don't get access. So we have about 2,000 patients currently in the county who are waiting for a retina consult. And that is what led to start of the Orange County AI project. Similarly, as a nonprofit that we work in areas, majority of the patients that we see in these attempts in countries like Bolivia, Belize, Haiti, Brazil, or in countries in Africa, majority of those patients are patients with diabetes and diabetic retinopathy, unfortunately, and they need to be provided care so that they don't have any visual problems later. So as part of Retina Global effort, we have volunteers traveling for a week to these areas. They see patients, they provide care. They also train people on the ground. And we identify a person who potentially then gets sponsored for a retina fellowship training wherever they're eligible to go to. And then once they come back, we provide them with instrumentation and infrastructure so that they can create a retina clinic and work there on a long-term basis. The ultimate goal is to create a sustainable outcome. My last slide about the Orange County AI project. We started this project last year, based on the fact that we have a huge number of patients waiting at this time. We in fact provide not just retina care, but also anterior segment care, which is cataract and glaucoma. Volunteer ophthalmologists from Southern California, outside Orange County, like in people practicing in LA, in Riverside, in San Diego, they all come in and volunteer their time. We've had industry support for this program. And we, as mentioned, we conduct this clinic once a month at this time, but we are increasing it to twice a month. And by next month, we'll also be starting to provide surgeries to these patients. And everything is pretty much done free of cost at this point of time. So, it's definitely a worthwhile program in terms of the fact that we are providing care who would not, if not for this program, they would not be able to access care otherwise. So that's it from me. Thanks so much. And I'll, again, thanks for this opportunity. And if there are any questions, I'll be happy to answer them. Thank you.
Thank you, Rajat. Thanks for bringing us up to date with diabetic retinopathy and your multifaceted approach to eye disease all over the world. It's amazing. There is a shout out from one of our members, Dr. Nandakumar, who probably, I believe, knows you. There's also one question in the chat box from Nisha regarding the role of fibrates. Do you have anything to say about that?
So there's been conversation about utilization of various different medications in terms of trying to control the disease, but it has not, fibrates at this point have not showcased benefits, so we don't really focus on those things, especially at this time.
So if we are running a little short in time, so I'm going to say that if you have any more questions for Rajat, I've left an email address for him to directly communicate it with. So we thank you, Rajat, again. We actually will move on. I stay on because we have a visual theme today, as I'll be telling you in a few minutes. We are moving on to a very special guest all the way from Dibrugarh on the eastern side of India in Assam. Is an inspiring young gentleman by the name of Vivek Sharma. He's an accomplished musician, a Visharad in Indian classical music from the Bangia University, Calcutta, as well as a double graduate from the Akhil Bharatiya Gandharva Mahavidyalaya in Pune. He has participated and received recognition in many regional and national level singing competitions, most noteworthy being on ZTV on Sarigamapa in 2018, where he turned out to be the top 77 out of 36,000 singers from India, Pakistan, and Nepal. He has won a silver medal for his musical talents. But the most or the less publicized fact about Vivek is that he is a differently abled artist, and he has only partial vision from birth due to an optic nerve anomaly. All his achievements as a musician have been accomplished in spite of this disability, which is why this very humble gentleman is an inspiration to all of us. And as Vivek himself says, he sees the world through music. So I got introduced to Vivek through a common friend, Govind Damani, who is an amazing singer himself. We will now play a short video of Vivek's song, and then try to bring him and Govind on Zoom for a brief period so they can say hello to all of you. It's early morning in Assam now. Thank you.
हर घड़ी बदल रही है रूप जिंदगी, छाँव है कभी कभी है धूप जिंदगी, हर पल यहाँ जी भर जियो, जो है समा कल हो न हो। हर घड़ी बदल रही है रूप जिंदगी, छाँव है कभी कभी है धूप जिंदगी, हर पल यहाँ जी भर जियो, जो है समा कल हो न हो। चाहे जो तुम्हें पूरे दिल से मिलता है वो मुश्किल से, ऐसा जो कोई कहीं है, बस वो ही सब से हंसी है। उस हाथ को तुम थाम लो, वो मेहरबान कल हो न हो। जी भर जियो जो है समा कल हो ना हो। साए पास कोई जो आए, लाख संभालो पागल दिल को, दिल धड़के ही जाए। पर सोच लो इस पल है जो वो दास्तां कल हो न हो। हर पल यहाँ जी भर जियो जो है समा कल हो न हो। दिल का भंवर करे पुकार, प्यार का राग सुनो, प्यार का राग सुनो रे ऊ। फूल तुम गुलाब का, क्या जवाब आपका, जो अदा है वो बहार है। आज दिल की बेकली आ गई जुबान पर, बात ये है तुमसे प्यार है। दिल तुम्हें दे दिया रे, प्यार का राग सुनो रे ऊ। दिल का भंवर करे पुकार, प्यार का राग सुनो, प्यार का राग सुनो रे ऊ। चाहे तुम मिटाना पर न तुम गिराना, आंसू की तरह निगाह से। प्यार की ऊंचाई, इश्क की गहराई, पूछ लो हमारी आह से। आसमां छू लिया रे, प्यार का राग सुनो रे ऊ। दिल का भंवर करे पुकार, प्यार का राग सुनो, प्यार का राग सुनो रे ऊ। तुझ संग बैर लगाया ऐसा, तुझ संग बैर लगाया ऐसा, रहा ना मैं फिर अपने जैसा, हाँ रहा ना मैं फिर अपने जैसा। मेरा नाम इश्क, तेरा नाम इश्क, मेरा नाम इश्क, तेरा नाम इश्क, मेरा नाम इश्क, तेरा नाम इश्क, मेरा नाम तेरा नाम, तेरा नाम इश्क। ये लाल इश्क, ये मलाल इश्क, ये ऐब इश्क, ये बैर इश्क, ये लाल इश्क, ये मलाल इश्क, ये ऐब इश्क, ये बैर इश्क, इश्क इश्क इश्क। अपना नाम बदल दूं या तेरा नाम छुपा लूं, या छोड़ के सारी आग में वैराग उठा लूं। बस एक रहे मेरा काम इश्क, मेरा काम इश्क, मेरा काम इश्क, मेरा नाम इश्क, तेरा नाम इश्क, मेरा नाम तेरा नाम, तेरा नाम इश्क। ये लाल इश्क, ये मलाल इश्क, ये ऐब इश्क, ये बैर इश्क, ये लाल इश्क, ये मलाल इश्क, ये ऐब इश्क, ये बैर इश्क, इश्क इश्क इश्क। ये काली रात जकड़ लूं, ये ठंडा चांद पकड़ लूं, ओ ये काली रात जकड़ लूं, ये ठंडा चांद पकड़ लूं। दिन रात के वैरी वेद का रुख मोड़ के मैं रख दूं। तुझ संग बैर लगाया ऐसा, तुझ संग बैर लगाया ऐसा, रहा ना मैं फिर अपने जैसा, हाँ रहा ना मैं फिर अपने जैसा। मेरा नाम इश्क, तेरा नाम इश्क, मेरा नाम इश्क।
Thank you for that amazing performance. Let's see, there's Vivek now. He's all the way in Assam. And our friend Govind there is helping him to come on Zoom here. There's Govind there. Govind used to be in LA before, and is an amazing musician. We used to be a part of a band called Indie Beats, where we all performed and helped each other. He's back in Assam now. You want to say a couple of words, Govind and Vivek? Please unmute yourself. Yeah.
Hi, everyone. So, first of all, I mean, it's a privilege to be, like amidst such great doctors, I would say. And yeah, what should I say about Vivek? He is a very dear friend, and Ravi knows about his, this vision challenges and everything. But leaving that aside, he is an amazing musician, and as he said, right, he sees world through his music. So I'm also trying my best to, like, if in a way, through I'm able to help in a very tiny way. So I mean, it will be an honor, and a blessing to me. So as I mean, you all would agree that like the last 3 songs which he had sung, so that shows his class and his metal. And I can request all of you that if you all have a keenness and interest in music, you can coordinate with him, you can learn some stuff. That's all I can say.
Thank you.
Over to Vivek.
Vivek bhai, anything you want to say, or?
Hello. Hello. Am I audible to everyone?
Yes.
Okay. Good evening, my friends in USA, and it's been an honor for me to be a part of this such a fantastic musical evening. I found lots of fantastic voices here. There is no dearth of talent in US, I have to say. We Indians are doing all kinds of stuff in music as well, apart from your profession in medical science. You guys are doing tremendously well in music as well. Especially, I would like to mention a name. A ma'am was there who sang that song, Baahon Mein Chale Aa. Wow, what a song! What rendition! Brilliant, ma'am Lakshmi. I would like to pass on my best regards to her through your platform. And yeah, a special thanks to Dr. Ravi Raghavan, who coordinated with me all this while. He was the one who inspired me to, come up with this musical thing for all of you. Special mention to Govind Damani, my friend, my brother. It's all because of his efforts that today I'm being introduced to all of you. And one name I would definitely like to put up here, who on the technical part, he was the one who arranged all the songs for me and mixed everything. His name, he's also one of my younger brother, he's a brother like figure for me. His name is Vaishampayan Bhaumik. He did tremendously well for me. He arranged all the musical thing for me so that I could sing these 3 songs for all of you. And I hope that you guys have loved my song. And thank you so much, everybody, once again, for listening to me and giving me a space in your world. Thank you so much.
Thanks, Vivek and Govind. There are multiple messages of appreciation in the chat box. I don't have time to read them all, but we'll send them all to you. So let us all wish Vivek the best and support him in his future endeavors. In some ways, we can help these talented artists in spite of their disabilities. Thank you all for listening.
We are almost at the end of the session, and thank you so much, everyone. And thank you, Vivek, for joining us. That was just fantastic. And we are so fortunate to be able to meet you, and we will be seeing you hopefully in the future. Thank you so much for singing for us. And thank you, Govind. Next, we have in the session, this is going to be a small musical quartet, we like to call. We just didn't get much time, but we have 4 of us from Southern California. We got together and we just did this. This is very unofficial recording that we did. Thanks to Ravi, Dr. Soni Thomas, he's a dentist practicing in Arcadia, and also our good friend, Justin James. He's a multi-talented person who can play drum. He's a guitarist. He can play guitar, he can play keyboard and sing also. So here we are, our AKMG California Musical Quartet, 4 of us here for you. Thank you.
അമ്പാടി പയ്യുകൾ മെയ്യും കാണാ തീരത്ത് അനുരാഗം മൂടും തത്തമ്മേ കുഴലൂതും മേഘം നെയ്യൽ ചായും നേരത്ത് കുളിരൊന്നൊരു കാര്യം ചൊല്ലാമോ നാടും കാണാം കൂടും കൂട്ടാം ഈണം പാടാം നാടും കൂടാം
അമ്പാടി പൈകൾ മെയ്യും കാണാ തീരത്ത് അനുരാഗം മൂളും തത്തമ്മേ കുഴലൂതും മേഘം മേൽ ചായും നേരത്ത് കുളിരുന്നൊരു കാര്യം ചൊല്ലാമോ
യദുകുലം അറിയാതൊരു രാവിൽ കരതരം കവരാനണയും ഞാൻ സ്നേഹത്തിൻ കൂടാരത്തിൻ നീയാണല്ലോ നാടും കൂടും പാടാം ചൂടാം
അമ്പാടി പയ്യങ്ങൾ മേയും കാണാ തീരത്ത് അനുരാഗം മൂളും തത്തമ്മേ
കുഴലൂതും മേഘം നെയ്യൽ ചായും നേരത്ത് കുളിരൊന്നൊരു കാര്യം ചൊല്ലാമോ
ും
ഒരു യുഗം ഞാൻ തപസിരുന്നു ഒന്നു കാണുവാൻ കഴിഞ്ഞ കാലം കൊഴിഞ്ഞ സുഖം പൂത്തുവിടുന്നു ഒരു യുഗം ഞാൻ തപസിരുന്നു ഒന്നു കാണുവാൻ കഴിഞ്ഞ കാലം കൊഴിഞ്ഞ സുഖം പൂത്തുവിടുന്നു മുഖമാവൻ മനസ്സിൽ ഗാനമായി നീയുണർന്നു മുഖമാവൻ മനസ്സിൽ ഗാനമായി നീയുണർന്നു ഹൃദയമൃദുല തന്ത്രിയേ ദേവാവരം വൈശാഖ സന്ധ്യ നിൻ ചുണ്ടിലെന്റെ അരുണ സഹിത നവകാന്തിയോ चुरा लिया है तुमने जो दिल को नजर नहीं चुराना सनम बदल के मेरी तुम जिंदगानी कहीं बदल न जाना सनम सजाऊंगा लुट कर भी तेरे बदन की डाली को लहू जिगर का दूंगा हंसी लबों की डाली को सजाऊंगा लुट कर भी तेरे बदन की डाली को लहू जिगर का दूंगा हंसी लबों की डाली को ए वफा क्या इस जहां को एक दिन दिखला दूंगा मैं दीवाना चुरा लिया है तुमने दिल को नजर नहीं चुराना सनम बदल के मेरी तुम जिंदगानी कहीं बदल न जाना सनम
Thank you so much, everyone, for listening to our unofficial quartet of AKMG California. And thank you, Ravi. Thank you, Sony and Justin, for driving all the way to my home. And we did this recording in last week. So it wasn't planned, and glad you all liked it. We are almost at the end of our session, and I'm going to invite our dear Radha Chechi, Dr. Radha Menon. She's not new to any of us in AKMG. She's like my own sister. She's my mentor. She's my everything, a guide, leader in AKMG for me. She's an internist and a geriatrician in private practice in Napa Valley, California. She's alumni of Madras Medical College. And she participates actively in leadership roles in the local hospitals and medical groups. She served as the convention chair for the Hawaii Convention in AKMG and also served as the president of AKMG Convention in 2008 in Newport Beach. She was regional director of API and has served in the Women's Committee in API many times. She was also convention chairperson of KHNA in Los Angeles in 2009. She's a compassionate, well-respected physician in our community, and she has proactive approach to patient care with primary focus on preventive healthcare with special interest in geriatrics and women's health. She hails from Ernakulam, Kerala. She's married to Dr. Achumenon Achuchetan, and has two daughters, Priya, she's the breast radiologist, and Sandhya, who's a dentist. Here is Radha Chechi. All yours, Chechi. Thank you.
Thank you, Sindhu, for that wonderful and a lengthy introduction. I know it's like the end of the night today, and even though it started as an evening program, I think it's going into the night, and I'll make it very short. It is really my privilege and honor to be here today to speak to all of you, and I'm so happy to see all of you on the screen or around the room, I would say. At the same time, my heart is very sad because we lost one of our dear friends, Dr. Joseph Ike, last week. Dr. Joseph Ike was one of the past presidents of AKMG from California. He was a great man with a great vision, and he was way ahead of his times. He was the first one to bring AKMG to the West Coast when he brought the convention to San Diego in the year 1992, and it was when Dr. Ram Tinakal was the president of AKMG. He continued to be very active in AKMG and was the convention chair for the Motherland Convention, and the only Motherland Convention we've had in Kochi so far, under the presidency of Dr. Matthew Thekade, and that was in the year 1996. He was also active in the Las Vegas Convention in 1999, which was held under the presidency of Dr. George Sebastian, late Dr. George Sebastian, who was also a great leader from California. In 2003, when Dr. Ike became the president of AKMG, he decided this is time to take AKMG offshore. So he held the first offshore convention of AKMG in Hawaii. And to this day is one of the most memorable conventions AKMG has ever had. And I'm sure all of you attended it still do remember it very well. He was a great leader. He was very well respected, a man of few words, a perfect guide, and an exceptional organizational skills and extraordinary vision. He was way ahead of his times, that's all I can tell you. And for me, he was a great mentor, a great loss personally for me. He will be dearly missed by all the AKMG members who are friends of his, and also especially the California team. We think it's a great loss that we lost you, Apu. Now, looking around in this room, or I would say around screen, there are many AKMG leaders here. Many of you are past presidents, and many of you are esteemed AKMG members and current AKMG members right now, and current office bearers. And all of you are, I consider, as my AKMG friends. It was very nice of you to spend this whole evening with us, and look, each and every one of you have contributed a lot to AKMG in your own way. That's the reason that this organization, which had its humble beginnings in an Indian restaurant in the 1980s in New York, has grown to this by leaps and bounds and has reached this state now. So as I look around, I see more and more new members being added to the AKMG list on a regular basis. And I commend all the new leaders for doing this. And it's very important for us that we keep our organization growing. When we first met, we had no cell phones, we had no emails, we had no computers, no internet, no WhatsApp, no Facebook, or nothing to communicate with each other. But somehow, we all learned to connect with each other and develop a strong bond amongst all of us. And that is the most rewarding experience of AKMG. This camaraderie, this friendship, and the relationship that we have all developed amongst each other is an experience that I really cannot explain to any one of you. It is something that we have to feel within ourselves. That is why I implore to all the new AKMG members who are joining today, I do want all of you to keep coming for AKMG. Please attend all the conventions whenever you're able to, because that is where you get to meet everyone and to see all the doctors who are the great doctors of AKMG and then get to bond with them. And that's very important. So I will say the next convention is going to be in Toronto under the leadership of Dr. Nigel Haroon, and his Toronto convention is going to be excellent. And I do want each and every one of you to try and attend that convention this summer. Is going to be in August. Following that, I think we have another convention that's lined up. Again, it will be a wonderful convention that will be done by the Detroit team under the leadership of Dr. Geeta Nair. And I think it will be, again, an awesome convention. We have had the last convention in California in 2008, and it was in Newport Beach when I was the president, and it was very well received at that time. However, I have to say, we are really ecstatic that we are going to bring another convention to California under the leadership of Dr. Sindu Pillai. Today, after watching today's program, you all know that I know Dr. Sindu Pillai and Dr. Ravi Raghavan are ready for the next convention. I hope you have enjoyed it as much as we have all enjoyed it, and I'm sure they enjoyed putting it together for you. So I'm sure we are looking ahead to a wonderful, wonderful convention under their leadership in 2024. It will be actually the 45th AKMG convention in 2024. And I will have to say that Dr. Sindu Pillai is very hardworking. She will reach out to each and every one of you, and you will see that she will be contacting each one. And I think it's going to be a wonderful affair in 2024. And Dr. Ravi is equally there with her, and he's always on the phone calling people, finding new people to join AKMG. And I cannot really comment how much both of them are working so hard for this. So what I can tell you, Sindhu and Ravi, keep this job going, and we will have a blast in 2024. Okay, so I'm so happy to see both of you organizing this evening together. And I thank all my AKMG friends, dear, from here in California, as well as from the East Coast. I know it's almost sleep time there. I do thank you for staying till the end of the program and being with us. Looking forward to seeing all of you in Toronto this year.
Thank you so much, Radha Chichi, Dr. Radhaman, for that very much inspirational speech for us. And yes, we are looking forward to that day in 2024. Now we are at the end of the session, and my job is to do the vote of thanks. I have a lot of people to be thankful for. The first and foremost is the audience. I know it's for a lot of you, it is past bedtime. It is 10:30. Almost 11 o'clock, and thank you for staying. A lot of you are staying from the beginning, from 7 o'clock onwards, and thank you for your valuable time. I would like to thank all the past presidents, leaders of AKMG, the senior physicians, the young physicians, our president, Dr. Nigel Haroon. We are all looking forward to have a fabulous time in Toronto, California. I'm sorry, in Toronto, Canada. California keeps coming, I'm sorry. Our Dr. Radha Menon, she's our mentor, she's our leader. Looking forward to working with you, Chechi, for the next couple of years. Dr. Ravi, like I said, he is my right hand. We worked together in the short period of time. We were able to put it together, and I'm happy that it worked out well, and we all liked our program. Thanks, Ravi, for bringing Dr. Agrawal and Vivek, all the way Vivek from India, for singing for us. Our wonderful speakers, Dr. Vinod Pillai and Dr. Rajat Agrawal, for the much informative speeches for us today, and for the CME credits. Lakshmi Nair, our melodious, fabulous singer from Arizona, for singing for us. Again, Vivek Sharma, thank you so much for coming, joining the Zoom from Assam, and all your melodious songs. Our tech crew, our tech team, Gregory, Susan, and my dear friends, Vinod and Baba. There was not even a single glitch throughout the event. You might have noticed it. They have been working behind the stage, behind the curtain, working on the Zoom with no audio or video issues. And thank you so much. Then I have to thank my CME team for helping me to get the CME. It wasn't easy. It wasn't an easy task because the CME rules have changed as of 2022. And Dr. Khalil, Ashraf, and Dr. Roji Jacob for getting the CME credits. Thank you so much. I have to thank Dr. Anu Iqbal for the beautiful flyers. He made every single flyer for me. Every time I say, Anu, we need this, we need that. He was so active, so integral part of the marketing the flyers for the show today. So if I have missed something, please forgive me. And again, once again, thank you to all for staying late for the show. And we will be looking forward to another event coming up soon. Definitely Toronto, August 4th through 6th. Thank you so much and good night.